Microphone test, 1, 2, 1, 2, microphone test. Microphone test, 1, 2, 3, 4. Everybody getting good levels? Okay.
Good afternoon, everyone, and thank you for being with us. We have two public hearings this afternoon. For those of you who have not handed in your copy of your copies of your testimony to the clerk seated at the podium to my left and your right, please do so upon entering the room. Please be advised that the clerk, if you are a substitute speaker for your organization, and speakers will not be allowed to cede time to another speaker. Speakers in each group should come up together, sit at the witness table, and remain there until all have spoken and the council has asked questions of the group members. Before beginning your presentation, please state your name for the record, and clearly for the record. And before beginning your presentation, please touch the red button at the base of the microphone. When you finish speaking, please cut that microphone off. When you begin your presentation, you have 3 minutes to speak. A yellow light in front of you will come on when you have 30 seconds left in which to finish your presentation. Please end your statement when the red light comes on. And if you've not finished your statement, the council will read your submitted written testimony and will consider it just as your oral testimony. We have the two public hearings. The first one is the agenda item number 12, which is amendments to Washington Suburban Sanitary Commission's, WSSC's, FY20 through 25 Capital Improvements Program. The T&E Committee tentatively is scheduled to take that up on March the 2nd, 2020. And that can't be. Today's the 3rd, so there's a mistake on that. Tentatively scheduled, we'll have to let you know when they will tentatively schedule to take that up. But there are no speakers for that hearing. And the agenda item number 13 is a supplemental appropriation to the county government's FY20 operating budget, Department of Police, in the amount of $1,436,172 for school safety FY20 school resource officers grant. Source of funds is the state aid. We have 5 speakers. Please come forward. Mark Pastor is an individual. Anita Lample from Jews United for Justice. Laurel Ho showing up for Racial Justice, Montgomery County. Delmas Umzar from CASA. And Hashim Jabbar from Racial Justice Now. If you please come forward. And Mr. Pastor, when you are ready, please begin.
Thank you, Council President Capps, Vice President Hucker, and Council members for this opportunity to speak to you today about the proposed supplemental appropriation to allocate approximately $1.4 million for school resource officers in MCPS middle schools. Today I am speaking for myself, not representing any organization. Sorry, my page. I strongly urge you to reject the request from the county executive to add SROs to every MCPS middle school. When I last appeared before you, I spoke about the need for more data about SROs in Montgomery County. Well, we still need more data, but there is some data available, data that MCPS is required to submit to the U.S. Department of Education. The most recent data that I have found is for the 2015-2016 school year, and I've made charts of that data, which I've attached to my written testimony, and I hope you have before you now. I want to call your attention to the fact that while in 2015-16, black students made up approximately 22% of MCPS high school students. However, black students were almost 50% of the students arrested in high schools. The data for 2013-14 shows an almost equally disturbing disparity. 22.5% of MCPS high school students were black, while they were 43% of students arrested in MCPS schools. When the community policing bill was being considered, we heard from some on the council that there wasn't data that shows that black students are arrested disproportionately to others. We now have that data, supplied by MCPS to the federal government, that refutes that argument. While the data doesn't tell us why these disparities exist, the data doesn't tell us why these disparities exist. The data doesn't say, nor am I saying, that all, some, or even any of the school resource officers are racist. The data we have doesn't tell us why the students were arrested or if they were convicted. The data doesn't tell us if other students engaging in similar behavior were treated differently. The data doesn't tell us anything about what led up to or followed the arrest. So we need to be careful about the conclusions we draw from the data. But, and this is very important, we do know that there are disparate results, that students in different groups are being impacted differently. This is happening today, not 10 years ago, not 20 years ago, but currently. The facts are clear. It's beyond dispute now. So I ask you to not expand this program that is having racially disparate results. Let's look at the root causes and understand those causes before we add SROs to our middle schools. Is the disparity because of the officers, the training, the policies in schools, differences in how behavior is perceived, or a whole host of other reasons that don't come to mind?
Yeah.
Please do not expand
Thank you very
the
much.
program
We'll
until we
read
know
the rest
more.
of your testimony.
Thank you.
Thank you. I'll have to do that. Okay. Next is Mrs. Anita Lampel.
My name is Anita Lampel. I live in Bethesda. Thank you for letting me speak. I'm here today on behalf of Jews United for Justice in opposition to the supplemental appropriation for school resource officers. I am by training a psychologist, and I worked for decades assessing children, adolescents, and the programs that affect them. I served on the Juvenile Justice Commission of San Bernardino County, and I worked with that Department of Probation. I also assessed children and youth for the court and juvenile dependency systems. My career taught me to be data-focused, to consider whether programs worked or didn't. Before you is a proposal to spend over $1.4 million on school resource officers to place them in middle schools. Jews United for Justice, the ACLU, the Silver Springs Justice Coalition, and our other partners oppose this. As much as anyone here, we want conflicts reduced in middle schools. We want young teens to feel safe and be safe in their schools and communities. We want them to learn how to solve problems and reduce tensions. School resource officers do not do that. Moreover, we have in Montgomery County a racial equity lens approved by this body and the county executive. This special appropriation could not possibly meet the metrics set by that legislation of not exacerbating existing inequities in our county. Let's consider what happens. I'm the parent of two outstanding men, and I watched horrified as one of them in middle school raised his fist against a soccer opponent because he thought that kid had fouled him. Now, imagine how I would have felt if I had also had to deal with lawyers, the juvenile court, and an arrest record, because that's where data shows that many boys end up over these kinds of episodes if a school resource officer is around. The Congressional Research Service in 2013 provided Congress with a report noting that an increase in the criminalization of minor offenses offenses on campuses with SROs and considered that a negative consequence impacting children living in poverty and children of color more. And a study in North Carolina reported by the Brookings Institute in 2018 noted no decrease in disciplinary outcomes in schools with SROs, but an increase in student arrests and juvenile court referrals. Referrals to juvenile court set a host of negative consequences in place for young offenders. Jewish tradition teaches us that destroying one life is akin to destroying the world, and I have to tell you, an arrest record does that to young people. Thank you very much.
Thank you. The next speaker is Laurel Ho.
My name is Dr. Laurel Ho. I am presenting testimony on behalf of the Silver Spring Justice Coalition, of which Serge Moko is a member. The Silver Spring Justice Coalition vehemently opposes the supplemental appropriation of over $1.4 million to expand the School Resource Officer Program into all 41 of our county's middle schools. We understand that the Montgomery County Police Department applied for and was awarded a grant from the state that would provide funds for overtime pay for current resource officers so they could have a physical presence in the middle schools in their assigned clusters in addition to the high schools. Just because the state will give us money for something does not mean the county needs to accept it. Our representatives have a responsibility to do what is in the best interests of our community members, especially those most negatively affected by council action. We have been told that no new SROs would be hired with this money, but expanding the hours of current SROs is the functional equivalent of increasing the number of SROs in schools. This plan was developed without consulting with teachers, parents, students, or racial equity advocates. Just last month, the County Council held a hearing where dozens of individuals and organizations testified against expanding our county's SRO program. The Council backed away from the bill's proposal to expand SROs in the face of data demonstrating how SROs accelerate the school-to-prison pipeline and data showing the high number of arrests made by our own county's SROs and the disproportionate rates of arrests of Black and Latinx youth. SROs arrest students of color and students with disabilities at disproportionate rates and feed the school-to-prison pipeline. There is no data showing that SROs protect students from gun violence. And police can still be called into schools when there is an emergency, which fulfills the state's Safe to Learn mandate. SRO advocates say students form relationships with and trust SROs, which in turn benefits our students. There are no empirical studies to support that narrative. A much better use of funding would be for more teachers, nurses, counselors, and school psychologists instead. Students deserve trained adults who aren't carrying weapons in whom to confide. We urge you to vote against this supplemental appropriation to put police in middle schools.
Thank you. Next is Delmas Umazor.
My name is Delmas Umenzor. I am here representing CASA. CASA is the largest immigrant right organization in Maryland, and we submit this testimony against the supplemental appropriation for school safety fiscal year 20 resource officer grant, which would expand the school resource officer program to put police officers in all 41 of our county's middle schools. In recent years, we have been working with and for first-generation immigrant students in Montgomery County out of our Pine Ridge Center in the Long Branch neighborhood, as well as in our various committees that include youth who are directly affected by immigration. Most of the youth we serve fit one of the two profile types: newcomer students or first-generation immigrant students. Each student profile type has unique needs, but both are underserved and face enormous challenges to success. Newcomer students are at very high risk for dropping out after arriving to the U.S. at a later age with limited English skills, interrupted schooling. Often they have unstable family relationships and are separated by borders, as well as they face recent traumas from their home countries and their journey. First-generation students face different challenges. As the most bilingual members of their households, they frequently play adult roles in their families, growing up faster than their U.S.-born counterparts because they are serving in a parent role to their families, navigating the healthcare system, the landlords, and frequently employers. And sometimes they experience immense traumas in their homes and communities, which put them in contact with law enforcement officials. Often, school provides for the youth that we serve a refuge for what they experience in their everyday lives. Countless reports have demonstrated that adding school resource officers is not effective in making schools feel safer, especially for youth of color and those that identify as female. In 2018, Brookings Institution report on the effects of adding SROs to middle schools revealed that adding SROs does not make schools safer. Instead of investing additional funding towards adding SROs to our middle schools, why not invest in after-school programs and preventative interventions that have demonstrated change in behavior, attitude, and decrease of violence and crime in schools? It takes about $6,500 to pay one student to participate in a year-long after-school program. That means that with the nearly $1.5 million allocated for SROs, you can get an additional 230 students in preventative intervention to ensure they are involved, active, and safe. CASA asks that the council reconsider the supplemental appropriation to increase SROs in middle schools, and to follow not ideology but concrete data and outcomes to inform policy that will make a positive impact on our students and youth. Thank you.
Thank you. Hashim Jabbar. You need to please cut on the bottom of the mic. There we go.
Giving honor and praise to the one true and living God. I'm going to be quite honest. I'm very uncomfortable with the way that this meeting is being held as a parent of two MCPS students. I'm very disappointed that a meeting directly affecting our children would be held in the middle of the day in such a manner. So I want to address that I feel disrespected, that parents should feel disrespected. This bill smells badly. Let me share some headlines. School to prison pipeline. For the record, I am a original black man, a Moor. So the dark-skinned people of this planet. So we know that this is a racist country we live in. Let's just be honest that this bill is ripe with racism, undergirding possibly. School to prison pipeline, white supremacy, prison industrial complex. Maryland leads the nation in incarceration of young black males. That means my son, this state is leading above Mississippi, correct me if I'm wrong, in incarcerating children that look like me. Maryland governor quadruples school safety and security budget after Parkland shooting. PA judge takes bribe to increase juvenile prisons into private prisons. Police called on black child over play money. Police shoot mentally ill black male. All of these directly affect people and children that look like me. I want to be direct because this is something you don't want your names attached to, quite honestly, and I think you really need some spiritual counsel because this is not righteousness. And quite honestly, you should be embarrassed. I'm embarrassed for you because this bill smells terrible. I've testified at I'm here as a parent, but also representing the Racial Justice Now DMV chapter, dedicated to overcoming institutional and systemic racism, specifically in education. I've testified at the United States Department of Education after the Parkland shootings and addressed the increase of police in schools in Ohio with the Senator Peggy Lehner, various sheriffs, and other chiefs of police, and I'll tell them what I told you, that there is no substantive evidence anywhere that police in schools make children more safe. Did I say anywhere? I say anywhere. If there is some, please present it. There is lots of evidence that shows police do not have good relationships with people that look like me that are full of your prisons, in that they hurt children, cause trauma, and disrupt education. Who said that police should be in schools?
Thank you very much.
Thank you.
Councilmember Rice.
Thank you, Mr. President. I just have a question for staff. If staff could approach the dais. I just want to understand, there have been some comments about what this supplemental appropriation, this is not a bill, this is a supplemental appropriation that was given via state aid Can we be very clear about what this supplemental appropriation is for, what it does, and what it's supposed to address when it comes to our responsibility as a county via state law?
Sure. Susan Farag, council staff for the record. My understanding is the police department applied for this last summer, and because of the way the state grant schedule works, we got it very late. So what it was initially meant to expand SRO coverage into middle schools, which is required by state law under the Maryland Safe to Learn Act, which is requiring SROs in all schools. It was requiring SROs in high schools last year.
Excuse me.
Ma'am, we're not asking for commentary. I'm asking for staff.
Much.
Thank you.
Since the money was received so late, they're using it as overtime for existing SROs and using that to put them in middle schools for more presence in the middle schools because the fiscal year is ending soon and the school year is ending soon.
And to be clear, we already have police in middle schools now, correct, that are covering some of our middle
I
schools?
believe there are 3 and 2 more getting ready to be deployed, I think, for the next school year.
Thank you, Mr. President.
Thank you. Councilmember Jawanda.
Thank you, Mr. President. So just to be clear, Ms. Farag, this is for expansion of overtime into middle schools, and you also mentioned that to me yesterday, or to my staff yesterday, that Chief Jones has a plan to expand to all middle schools?
Yes, he does, and I don't know the details of that yet. He did mention that additional training is needed because middle school kids are different from high school kids, and he's going to ensure that SROs get the appropriate training before that's fully deployed. And of course, it also depends on funding.
Right. And you're not aware of any additional training that the current officers that are in middle schools have received, are you?
I'm not, but I can follow up on that.
Okay, that would be great. And Mr. Tibbetts, could you come down for a second, please? Representing the county executive. Since this was submitted on January 15th of this year, is it still the county executive's position that he wants this supplemental appropriation?
We'd like to investigate uses of this money for, again, we're so late in the year, and if there's alternative uses for the money that are acceptable to the state.
That wouldn't necessarily mean the current stated use, which would the appropriation will fund overtime for personnel for adequate school resource officers to all MCPS middle schools. So different than that stated purpose in the memo?
Yes, different than that stated purpose. He would like to investigate alternatives to that stated purpose.
Such as training or some other usage, potentially?
Potentially. We have questions into the state right now to see what possible alternatives would be acceptable.
Okay, well, I appreciate that, and I'm sure you will, but please keep us posted. I think we don't want to forego state money, but we don't want to add, without a full analysis of this program, which we've discussed here. We're going to have a joint committee, I hope soon, between education and culture and public safety to dig into the data. There's been a lot of dispute on what the data is. I've worked with Mr. Pastor. I've seen that data, and it's concerning, and I think we need to dig into it before we consider any expansion anywhere. And we need to know what the training is. There's just a lot of questions here. So I'm glad that we pulled it off to the schedule to vote today. But there's a lot of information we're going to need before I'm comfortable, and I think others, in moving forward with this. So please, as the county executive has those conversations with the state, we need to be kept up to date in real time.
Okay?
Thank you.
Thank you. And could I ask Mr. Jabbar to also turn off your microphone, please? There we go. And next is Councilmember Ream.
Thank you. I am also glad we're not voting on this today. I don't support the expansion into middle schools, but we need to get to the bottom of this question of state law. Susan just said that there may be a requirement in state law. I think that needs to be part of the discussion because I've heard different views on
The
that
text
issue.
of the bill, I'm sorry, Councilmember, the text of the bill says SROs in all high schools for last school year, and then SROs or a quote, local law enforcement presence in this school year in all schools.
Presence. That was the text of the state legislation.
Yes, and it was the concern of the council and the Public Safety Committee during that time, during the police operating budget deliberations, whether or not that was going to be a significant fiscal impact on the county if we were required to have actual SROs in those middle schools.
Correct.
All schools, I'm sorry, but
We must have 50 middle schools in the county. That's like
40 or 41.
an entire police department to have an officer at every middle school. Okay, well, I think we need to really explore what our obligation under the law is and what is our range of options to do that, because having a presence in the schools could mean a lot of different things. I think that is something that will need to be a part of this discussion when it goes to the committee. Thank you.
Thank you. Councilmember Rice.
So thank you, Mr. Joando, for bringing up Mr. Tibbetts, because I'm a little bit perplexed. When the county executive served here on the county council, he was the chair of the Public Safety Committee, and over the years, we expanded the police officer, the school resource officer program from 2014, when it was actually about to be disbanded, to where it stands now in every single high school and some middle schools. In fact, the expansion into middle schools was something that actually County Executive Elrich cast as one of his last votes as chair of public safety. And so now you're telling me that the county executive has switched his position?
Since then, there has been a much more public discussion about the role of SROs in our schools, and particularly now the discussion in the middle schools. And he wishes to revisit that role of SROs in our middle schools.
Interesting, because those same conversations were being had then. I know because I led the discussion in terms of the school resource officer program, and know that there were the same concerns that were espoused then are the same concerns that were espoused now. In fact, the data that folks are referring to is oftentimes 4 to 6 years old, so it reflects that time frame that we were talking about from the SRO program. So just very interesting. Thank you.
Thank you. Councilmember Friedson.
Well, I appreciate Councilmember Rice's comments. I can't speak to the county executive's views while he was a council member. I wasn't here, but I am really concerned about the fact that, as far as I can tell, up until this morning, what we have in the packet and what we have before us is the official position of the executive branch. And so while I appreciate the fact that there have obviously been a significant public discussion in the county and throughout the country and beyond about these issues, I find it somewhat perplexing that there have been new information between the printing of the packet or last night and this morning, where there would be a significant change in the executive's position. Not weighing in specifically on this issue, whether we should delay or not, but I just find it pretty troubling, and that we would be in a position where we were about to vote on something as of 12 hours ago and had no knowledge or understanding that the county executive wanted to rethink his position or was going to pursue alternatives to the funding. Have there been discussions internally in the executive branch about that while this was on the agenda, or was this a decision that hadn't been discussed and only was determined this morning when there was notification to the council of that change?
Of course, it didn't happen this morning, but there has been significant discussion internally about the appropriateness of the SROs in the middle school and how these funds would need to be expended, and if there is alternative methods to use these funds for the purpose that I think we want SROs for, is in order to help keep our students safe, and that can take different roles. It doesn't require a police officer to keep our students safe, to have people that they can confide in. So
did those discussions occur prior to the submission of the supplemental request from the executive branch to the council? or subsequent to that?
Subsequent.
So up until the printing of the packet and the formal request to the council, this was not under consideration by the county executive, but once the packet was printed and there was concerns that were raised, the SRO program broadly and the specific school resource officer presence in middle schools has raised concerns. Is that accurate?
I would say that's accurate, yes.
Okay. Thank you.
Thank you. Councilmember Reamer.
Thanks. I just want to point out why this has been a somewhat disorienting experience, to state the obvious. We have had a very public discussion now for quite a while about middle school SROs. We had legislation, we had a public hearing, there's been a shift in the legislation. Before the council, it was amended to remove a clause that had included that. It's been very, very public. So to have the executive then seek funding for the expansion of the program and recommend that to us is disorienting. And I think we would tend to assume the executive would not support the expansion to middle schools. And yet there is an appropriation request that will double down on that. So it is just very, I don't understand quite what's going on. So I think you can appreciate our reaction. And, you know, this has been a very public deliberation for quite some time. So you can understand the confusion here.
Can absolutely understand the confusion, and we do have to understand, as Susan, the staff talked about the state law, what our obligations are under the state law. So this packet was submitted to the council in January. We're getting to it now. Since then, there has been significant public discussion about it. That's what our deliberative process is about. The request from the executive was to not vote today. That was our request to the council president, so that we'd have the opportunity to have folks testify and duly consider the bill or the appropriation.
Thank you. Councilmember Giwando.
Thank you, Mr. President. So, just so I'm clear, Mr. Tibbetts, and I see ACAO Sturgis in the audience. If you have anything to add, you're welcome to come down. If you don't, that's fine. Who oversees the police department? Are there active conversations with the state about the meaning of this law?
We have had OMB staff in contact with the state about the appropriation, so the meaning of this law that I am unsure of. About how the appropriation.
I didn't understand that. Say that
The
again.
appropriation, how the money was required, or when it would be spent, how it was to be spent, and whether there were modifications that could be made to that appropriation.
Consistent with the Safe to Learn Act.
Right.
Okay. So
about
OMB's
the actual State to Learn Act again, to my knowledge, that doesn't mean that it isn't happening. To my knowledge, there hadn't been active conversations with the state about the law itself, interpretation of the law itself.
Okay. Ms. Sturgis, do you have anything to add on that point?
Good afternoon. Caroline Sturgis, Assistant Chief Administrative Officer. To my knowledge, I am not aware of any conversations that we have had with the state regarding the law. But as Dale was mentioning, we did make a request for a modification to the grant application to see if we can use it for other expenditures, other activities beyond having school resource officers.
So there was a request made to the state about whether you could use this money for other things than were stated in the initial
other activities that were originally stated in the
so-
application.
And presumably, the state isn't going to give you guidance that's inconsistent with their interpretation of state law. So, but I think we need to have a finer point on, as you go back, that was raised in testimony. It's been raised by several of my colleagues, by Councilman Reamer in particular. We need to understand what we are and aren't allowed to do. We might need to get an Attorney General opinion if there's not regulation around it. I think it's a key point. That's one issue. I share my frustration with the delay in this position. I think it's the right position to wait, and substantively, because of the unclarity, but I would agree with my colleagues that the timeliness was not right. But that aside, let's not lose the forest for the trees here, that the larger substantive issue of should we be expanding this program and how we should be using our money, very precious money, whether it's state, federal, local money, to keep our kids safe and to give them what they need. That is a very real and active debate, one that we need to have, regardless of this specific issue. So I hope you will take that back. I appreciate the testimony.
Thank you. Councilmember Friedson.
Thank you, Council President. I appreciate all the comments that have been made. I have a few clarifying questions based on comments that were made after I spoke. The first is the request to the state. Was that made in writing?
Yes, that was made in writing in accordance to the grant adjustment process, grant adjustment notification process.
And when was that made in writing?
That was submitted in January. I have to confirm the actual date.
Request for the appropriation, the request for the clarification of state law of how this money could be used or couldn't be used, that request that you were referencing earlier to Councilmember Jawanda, was that made in writing?
No, I apologize. No, I thought my statement was I am not sure if there had been any conversation regarding the state law. What we did make a request on is a modification of how to use the grant that was awarded. We made a written request to see if we could use it for other expenses beyond school resource officers. That was made in writing.
And presumably the modification is different from the description of what the appropriation request that was submitted to the council? I mean, it's appropriation. Appropriations
Correct.
are made for specific purposes. We have a very specific purpose that's in the packet. You stated earlier that there was a request for a modification for the specific purposes of whether that would be allowable since this is state money. What I'm asking, if I'm not being clear, is whether the specific specifications for the use of the funds that was submitted to us that we were, as of, I don't know, a few hours ago, supposed to be voting on, whether that was the same as what was being requested to be modified.
Right. Yes, correct. What we're asking for is, in addition to what has been submitted in the packet, is to ask for an expansion to use it on additional expenses.
When was that requested modification sent to the state?
Yeah, that modification was in January. I would have to look it up and get back regarding the exact date.
So this was sent to us with a specific use in mind, while the county executive and administration were requesting different uses for the money? Am I following?
Expansion.
An expansion is a different use of the money. Could you make sure that council staff and council members have that, all the written information that was formally sent to the state on behalf of the county related to an appropriation that it sounds like is quite different from what was presented to us, which is pretty deeply troubling?
We will.
I appreciate that. And then I appreciate the comment earlier about a deliberative process. I got to be clear, this is anything but a deliberative process. And regardless of what anybody might feel about this particular issue on school resource officers and their appropriateness in schools and whether or not that's a good idea or a bad idea, I think that's a very important public policy discussion and debate we ought to have, and I'm happy to have it. But there's nothing deliberative about what happened here regarding this item. For months, the county has been pursuing something unbeknownst to council members. We received a supplemental appropriation that we were being requested to vote on today. There's public notice. There are all kinds of ways that a true deliberative process is supposed to work. And the county executive and the administration seems to be completely upending that process in the last minute, not delaying a position, but changing and reversing a formal position that's in writing. We're having a public hearing here to get input from community members. How can they possibly be providing legitimate views on a specific policy proposal if they don't know what it is? And how could they possibly know what it is? Because we don't know what it is. And up until now, when you have shared with us this dramatic change from what was provided, it is not the same. And so I just don't think that this is the way to do public policy. This is not the first time we've had this issue, but this is not transparent, it's not accountable, and it's not the way the process is supposed to work. It's not fair to the public, it's not fair to us, and it's not the way that Montgomery County should expect for its public policy to be handled.
Thank you very much. There's no other lights on. This public hearing is now closed, and we will have an action scheduled at a future date. I did want to go back to the item just before, as this panel is leaving. On the public hearing on WSSCs, the T&E committee work session was held on Monday, March 2nd, and that's the reason it said it that way. And of course, that public hearing is now closed. And anyone who wishes to submit additional material for the council's consideration should do so before the close of business today, March 3rd, so that your views can be included in the material which staff will prepare for the council's consideration. We now are going to go and sit as the Board of Health, and we're going to receive an update from about COVID-19, which was formerly called novel coronavirus, and as from the County Public Health Planning. And Linda McMillan is here somewhere, I believe, and she's coming forward. And Dr. Travis Gales, is he here as well? Okay. And he is coming as well. And go ahead. Go ahead. Just in case you. They're coming forward, and Dr. Earl Stoddard is here too. As they're coming forward, I did want to recognize and thank Ken Reichert from Senator Cardin's office for being here. Shebra Evans, the president of the Board of Education, is with us. Andy Zuckerman, who's the COO of Montgomery County Public Schools, is here, as are other people from the Board of Education. Casey Caseman, who? Oh, yeah, I have a list here. Casey Caseman from the County Exec's office. We also have Ms. Rochelle Rubin from the Assistant Superintendent of Office of Student and Family Support. Mr. Doug Hollis, the Executive Director in the Office of the Chief Operating Officer from Montgomery County Public Schools. Dr. Manifa McKnight, Deputy Superintendent, is here. And I believe someone is here from Senator Van Hollen's staff, and in the back. How are you? Good to see you. And someone from Congressman Raskin's office is here. We have a couple people from Congressman Raskin's office as well. And Dr. Gales, thank you for being, and Dr. Raymond Kroll is here from HHS. We have many, many people, and we're pleased everyone is here. I don't know who's going to be leading this off, but Dr. Gales or Dr. Stoddard, it's good to see both of you, and we appreciate this update, and whoever would like to begin, please begin.
I just want to say thank you, Council President Katz and members of the County Council Board of Health for entertaining this briefing today. We're very much interested in having a good conversation and certainly provide information to the public about how we're already responding and sort of how we expect this to play out in the weeks and months to come. I think we can very much say that things are changing. They may change while we're in this briefing, so please do understand we will try and provide the most accurate information up to date that we can, and we'll continue to do so as we move forward. And with that, certainly Dr. Yales.
Well, good afternoon. Thank you, Dr. Stoddard. Good afternoon, Council, Council President Katz, Board of Health, HHS Subcommittee, and everyone in the audience. I hope this excitement continues with all of our public health initiatives that we tackle.
Could I ask you to move your microphone over just the slightest bit? Thank you.
There we go. All right. So in the interest of time, we'll move through our slides. As Dr. Stoddard mentioned, the subject is very dynamic. And in fact, there will be several corrections that I make to the slides that were finalized this morning at 9, and there's new information coming in. So please indulge me with your patience. So just want to give a sense of where we stand. These are the most up-to-date numbers as of this morning, as of 8 o'clock this morning. In terms of cases in the United States, these numbers do not include individuals who were repatriated, in particular those who were quarantined on the Diamond Princess cruise ship in Japan. So this is where we stand. The top numbers represent nationally, and the bottom numbers represent case counts in Maryland. I do have some updates to that. As of earlier this morning, we had 6 patients who had received COVID-19 testing. That number is now 8, and we have 3 results pending. The number of negative test results so far that have come back have been 5. And this is consistent also with the District of Columbia that has not seen any cases, and the Commonwealth of Virginia, particularly Northern Virginia area. Even though there have been suspicious cases in each of the jurisdictions, all of those cases have, up to date as of this morning, have come back negative. Next slide. So really want to actually spend a little bit of time making sure that you are the most educated Board of Health in the state of Maryland when it comes to COVID-19, but in particular to the folks at home. If you watch the news over the weekend and lots of the newscasts, we throw around a lot of terms, but there's been very little discussion as to actually what is COVID-19, what are the symptoms, how do you test for it, and where do you go? So I would actually like to spend a little bit of time not indulging too much in the pathophysiology, but I do want to use some science to explain how the disease functions and also give background as to why there's such diversity in terms of how folks have responded. So particularly in the setting recently over the weekend where we started to see domestic cases pop up that are not tied to a significant travel history or exposure to a high risk or medium risk individual. And 2 of those cases unfortunately have passed, and I think actually there's 6 now. So I want to explain the science a little bit to give context as to why there's so much variability in response, and to also hopefully reassure the overwhelming majority of folks here at home and in our community that we are at low risk for contracting it, and even if one contracts it, they're at low risk for having a severe outcome. Next slide. So this is what coronavirus looks like, or COVID-19. It's important to explain to folks that coronavirus is a generic, it's not a generic term, but it's a specific term that refers to a family of different viruses. The common cold is a coronavirus. SARS, that we saw several years ago, is a coronavirus. COVID-19, which we're talking about today, is a novel strain. And when we say novel strain, what is meant is when we have done the genetic analysis and sequencing of the viral strain, it is something that we've not seen before. And because it's not something that we've seen before, that makes it a little bit challenging in terms of designing medical interventions and therapeutics, as well as being able to test properly for it, because again, this is something new. But just because it's new does not mean it's not something that we're not entirely familiar with in terms of the family of other viruses within the coronavirus family. Next slide. So this is a picture of your lungs. This is what healthy lungs look like. It's a cartoon. The blow up shows alveoli. So when you breathe in air, it goes through your nose, goes through your trachea, goes down to the bronchi, goes into each lung, and after the bronchi, it goes to the bronchioles, and ultimately lands in the alveoli. Next slide. So the alveoli is where the action happens. The reason why it's important to breathe is you need oxygen. All right? So you need oxygen to breathe. Your body needs oxygen to perform its essential functions. But the other component of breathing is you also need to get rid of carbon dioxide. Carbon dioxide is a major waste product of all of the different functions that keep us standing and alive here today. And if you have proper lung function, you're breathing in oxygen, getting oxygen delivered to your tissues. Again, you can see the schematic. Oxygen comes through the membrane of the alveoli, goes to the bloodstream, is taken back to the heart. The heart delivers it to the rest of the body, but it also picks up carbon dioxide, that waste product, and allows you to breathe that out and expire that into the air. This is the equation of life, or at least how I was taught in physiology. It's the Henderson-Hasselbalch equation. I don't put this up there for you to remember and to scare you. And for everyone at home, or the physiologists in the audience or at home, this is not meant to be a super specific explanation of this. But what I want you to understand is when this equation goes wrong, bad stuff happens. If your pH goes up or your pH goes down from baseline, your body does not like that. It is not equivalent to healthy living. So take a step back. If I've told you that your alveoli are the place where you have gas exchange, and if you have impaired gas exchange, you're not able to breathe properly, you're not able to get in oxygen, where do you think coronavirus or COVID-19, one of its most prominent sites of action, are? It's on the membrane of the alveoli. Now, we are developing a better understanding of the exact mechanism of action of the virus, but many viruses in that coronavirus family do impact the alveoli. So you can imagine if it's causing inflammation and changes to that membrane, it's impairing your ability to take in oxygen properly and to get rid of carbon dioxide. So what happens when what do you think if you can't breathe properly? What do you think those symptoms are going to be? You're going to have shortness of breath. You're probably going to have a cough because you're trying to cough up all of the junk that gets into your lungs when they're congested, secondary to inflammation and infection. And you're going to also have a fever because that's your body's systemic way of dealing with infection and inflammation. So it should not surprise anyone that the biggest three symptoms of COVID-19 are fever, shortness of breath, and cough. They also are similar symptoms to a host of other illnesses, which again makes it very difficult in terms of being able to diagnose. And I want to leave this equation up just for one more second to also explain a little bit about why there is such variability in terms of mortality. If you are a healthy individual, and I know this term has been thrown around a lot over the news, the underlying medical conditions. I think that's what was talked about in the press conference. If you are an otherwise healthy individual, where you have a healthy immune system, there's no reason to think that your immune system is not intact, and you can respond appropriately, you can contract COVID-19, develop those symptoms, be sick for a few days, but convalesce and do very well and return to your normal status of health before you contracted the illness. Now think about individuals who may have compromised systems that may predispose them to not being able to have a healthier outcome. So individuals who are already suffering from a host of medical conditions, whether acute or chronic. Those of us who are older, because that can have some impact in terms of your ability to respond, and individuals who may have some type of compromise to their immune system, which impairs their ability to effectively mount a response to keep the virus in check and keep it from wreaking havoc on your lungs and other areas. So we're done with the equations for today. We'll move on to more simplistic, hopefully, conversation. So just want to mention about the level of contagiousness of the virus in comparison to other things. This schematic is from World Health Organization that looks at if you have one person who's infected with a particular illness, on average, how many other people would that person as an individual likely to infect? And so the higher the number, obviously, the more contagious, and measles is highly contagious in comparison to the rest. But when you compare COVID-19, you can see how it compares and stacks against influenza and the SARS coronavirus from several years ago. And it's important to also highlight, I did not include specific numbers, but when we're talking about COVID-19 where we have not seen any cases, and in fact, we've had 8 suspicious cases across the state of Maryland in the last 6 weeks. We've had thousands of cases of the flu and over 20 deaths of the flu in the flu season this year, just to give context in terms of where we stand. Next slide. So we've talked a little bit about the clinical symptoms already. Again, the top 3 symptoms, fever, cough, shortness of breath. I also want to emphasize, take this opportunity to explain to folks why you may hear people talking about a 14-day period. What does that mean? So the 14-day period refers to the incubation period of this particular virus. As best as we can understand, based upon the genetic sequencing and analysis of COVID-19, is the incubation period is 14 days. That means that time period incubation period refers to when you are exposed to an agent or a certain condition and the time it takes for you to develop symptoms. That period is 14 days, as best as we know. So it means that if I came into contact with COVID-19, it will take up to 14 days, as short as 2 days, but up to 14 days before I develop symptoms. Now, after that 14th day, if I've not developed symptoms, we feel very confident that you are negative for the disease. And so that's why when we have talked about COVID-19, this is why the 14-day period is talked about, because that is what's considered to be the incubation period of COVID-19. And if an individual clears that 14-day period without developing symptoms, we feel confident that they are not carrying the disease. Next slide. I wanted to highlight what the most up-to-date criteria are for testing. This has been one of the more controversial items, and I'll be perfectly candid, I will shy away from any type of editorial comments and just simply refer straight to the data. This is the updated schematic from CDC in terms of those who are considered to be high or medium risk and require testing. Originally, the geographic component was confined to individuals from China, originally specifically in Wuhan. In that area, it was expanded to China, and over the weekend, there were additional additions, including Iran, Italy, Japan, and parts of South Korea. The clinical features have stayed the same. The epidemiologic features have changed a little bit, again, tied to those updated travel histories. Next slide. Just to reiterate this concept of underlying medical conditions, this is some preliminary data based upon the epidemiologic information from China, that the death rate for people with no health problems for COVID-19 is 0.9%. However, the data suggests that number rises when you start adding in other medical conditions such as hypertension, longstanding lung issues, including smoking, diabetes, and heart disease and other conditions. Next slide. Transmission factors. Again, some of this is redundant, but bears repeating. It is spread by air, close personal contact, touching surfaces. I was talking with a reporter outside, and we had a moment where we went to shake hands, and we paused a little bit because we know that the surfaces of hands are a place where germs can live, and so fist bumps and elbow greetings and things like that decrease and minimize exposures. Because the reality is, when you cough, where does it go? Most people cough on their hand. We're actually encouraging people to cough in other places, such as in your elbow, because your hand is what's going to touch the doorknob. It's going to touch the desk. It's going to touch everything that you come into contact with. And guess what? I'm going to come right behind you and probably touch those surfaces and pick those up. So, as it should be no surprise to anyone, this is one of the big reasons why we have been encouraging from day one, and will continue to encourage until the end of the world, effective hand washing as the preeminent way to prevent disease spread. And there has been, just to mention, some comment that there may be potential spread in feces, as there has been a gastrointestinal component associated with COVID-19 that is less understood. Unfortunately, I don't have any more information to share with you, as that is being tested out a little bit to better understand what that relationship is. Next slide. So just to remind you of prevention measures that are in place. Again, we have been preaching this from not only the beginning as we saw COVID-19 cases come up, but all through flu season every year, is washing hands and practicing good hand hygiene. If you are sick or symptomatic for whatever reason, encouraging you to avoid close contact with others, and that may potentially mean staying home from work or staying home from school. Making sure that surfaces are cleaned. As I mentioned before, COVID-19 outside of the body is not necessarily the strongest virus, meaning that if it's on surface, it's susceptible to soap and water and alcohol-based cleaners and so on and so forth. One of the controversial points that has come up is the concept of, do we need to wear masks? From a public health standpoint, the Surgeon General came out this weekend and emphatically said that masks, if you are a healthy person, don't carry utility in terms of protecting you. It's not recommended. We do recommend for individuals who are symptomatic or ill, we do say wearing masks are helpful because that prevents you from potentially spreading to someone else. And so as part of the process, I know that lots of people have asked for them, and certainly as evidenced by the fact that you can't really get them anywhere, a lot of people have bought them. But again, emphasizing that hand washing has been tested time and time again as the most effective way of disease control over wearing masks. Next question. Now, I want to actually highlight that this slide is inaccurate, because as of this morning, this was our testing protocol. Up until today, all of the tests in Maryland were sent through the state health department and sent to CDC for analysis. I'm happy to report that the state notified us this morning that the state can now do testing in the state of Maryland. We do not have to send those to the CDC. However, the protocol for county folks stays the same. What we're asking to do, and the state is asking for providers to do, is if you have a case that you are suspicious for, is to contact us at the local health department and or the state health department to get a consultation in terms of asking more questions and determining if the individual does need the test. Once that consultation is completed and the decision is made whether or not to move forward in terms of providing that test, the provider collects the samples per the testing protocol. Again, I won't bore you all with those details, but we'll collect the specimen. The specimen will be sent to Baltimore, and the state lab has the capacity and capabilities of running those tests. This is significant because when we had to send the test to Atlanta, there was a time lag, so it was taking up to 72 hours to get a test result. So you can imagine how that extended time period might complicate an individual patient's clinical picture, but also impair our ability to do the contact tracing in a timely manner to get a sense of other individuals who may have been exposed to that individual. So just wanted to update that. This information will be communicated by the state to hospitals and healthcare providers through the different licensing agencies. And we will, as we have done over the past week, in communication with our hospitals directly, provide that up-to-date clinical management, as well as to our safety net clinics who are part of a lot of the county programs. Next slide. One other additional recommendation that the state has put out, and we support, is this concept of creating a preparedness kit. Because in a worst case scenario, if we have to escalate our response and folks may have to self-quarantine and spend time at home, or if schools and businesses are closed for an extended period of time, making sure that they have some essential products at home. So things such as pain relievers, fever reducers, hand sanitizers, soap, other items. Also, if individuals have prescriptions that they need to fill that are about to run out, making sure that you have an adequate and necessary supply of those types of materials.
I just want to add that with those kits, we recognize that not a lot of our residents know where they're going to get their next meal today, let alone whether they can save food or do a preparedness kit. So, in thinking about that, the messaging that we're essentially putting out there is those who are capable of doing some of these things,
do them not just for their benefit, but for the benefit of everyone, so that when we get more into this, those people who don't have the opportunity to stockpile will still be able to go, even if the supply chains are interrupted, they will not be interrupted in such a way that you won't be able to go to the grocery stores. And so just by depressing the load that may be put onto our grocery stores or pharmacies now, we can actually protect people who may not be able to do the same stockpiling today. And so we're very cognizant of the fact that we have a variety of different residents who have very, very different means of preparing for themselves. And those of us who can prepare have a responsibility to do so to help protect those who can.
All right. So I want to shift gears a little bit and talk about how we have been responding up to date, and to give a sense of how we've been working. Next slide. So from the very beginning, back in January, we have been a part of, and I say we, myself, Dr. Stoddard, other members of our emergency preparedness teams have been a part of national, state, and regional networks. And so that includes weekly calls with the CDC, weekly calls with the state, and that also includes in-person meetings with the health officers, with the Secretary of Health, as well as with the state epidemiologist, Dr. David Blythe. Regional coordination in terms of numerous weekly calls, as well as in-person meetings with the Council of Governments that have included meetings that are just the health officers, meetings with health officers and emergency preparedness staff to be able to walk through and talk through cross-jurisdictional issues. And again, these conversations have been ongoing since January. A lot of this has been in the background, recognizing that we may need to escalate the response. So we've been doing a lot of contingency planning. In addition to that, we have had a number of other interjurisdictional communications that are a little bit less formal in terms of, for example, constant communication with health officers in other areas and other parts of the country to get updates. And lastly, we've had a significant amount of interagency communications with all of the different agencies across county government. Each of them would probably say we got a lot of homework assignments that we sent out last week to different agencies to begin thinking through continuity of operations plans, and the county executive has given the directive for agencies to formally review those. But we recommended to start thinking through those and some critical questions. And to highlight one partner, for example, MCPS from the very beginning has engaged us in terms of talking through strategies, in terms of how to communicate effectively with parents and students. And they have been a great partner in that endeavor in terms of making sure that comprehensive quality information is being delivered in a timely manner to address parental concerns, as well as start planning should we need to make decisions around closures and so forth. Next slide. To give you a sense of the timeline in terms of other communications, we sent our first letters to staff and employees related to COVID-19 back in late January and early February. We began formal interagency discussions around COVID-19, including the formation of a county website to provide information that is very thorough and is linked to the state and federal websites that are being updated on a daily basis. We also, that was also the time where we began interjurisdictional correspondence to discuss response coordination, to answer a lot of the questions that I'm sure people have, be like, well, what do we do? You know, what are we talking about? We've been discussing those for at least a month now and building consensus around those should we need to escalate a response. And want to emphasize that we have been doing even though a lot of the execution is at the local level, none of this happens in a vacuum. It's within constant coordination with our colleagues at the state, as well as getting information and guidance from the federal level and folks at CDC and HHS. I do want to also highlight another area that we have done on a local level, because we recognize that even though we've talked a lot about science, and I know we'll talk about this a little bit more and maybe some of your questions, is this concept of, because this came from a specific geographic area, we have seen concerns in certain groups about their risk, but we've also seen a high amount, well, not a high amount, but we have seen evidence to suggest that there is some xenophobia and stigma in our localities. And so we spent, thankful to the staff of the Office of Community Affairs within Health and Human Services and the Asian American Health Initiative, engaged providers within the Asian American community back in early February and spent an afternoon meeting with providers to talk about how to do focused messaging to that particular community, as well as address a lot of the concerns, specific concerns folks had. You know, should events be canceled? How should we go about educating folks and managing folks, particularly given travel histories for a lot of folks within that community. And we actually did a site visit and met with a fair amount of those seniors to talk through some of those questions as time has moved forward. And one other thing I want to highlight that the team did, but also remind folks within our community. So, a news outlet called us and said, hey, you know, we're getting reports that business revenue, for example, at Chinese restaurants are going down. What do you recommend? And my comment was, if you want to eat Chinese or any type of food, go to that restaurant. There's no reason not to go. And so staff from HHS on last Friday went, and I'm blanking on, I think the restaurant was China Garden in Rockville, but we went and had a meal. And 5 days later, we're fine. And we're okay. And so what I want to emphasize to folks is support your businesses. There's no reason to be afraid to go to a restaurant of any choice of any kind because that's not going to predispose your risk of contracting COVID-19 at this moment. So I want to be clear on that. Next slide. So future directions and operational considerations, which I think is a large majority of why we're here, to talk through some of those issues and answer questions. Want to highlight two things. So there have been a lot of questions popping up as to who makes the determination and what is the criteria in terms of school closures, business closures, so on and so forth. So the COMAR regulations sections 1006, 0106 lay out those necessary actions, and that responsibility falls within the purview of the health officer. And I want to make sure that folks understand that even though that falls within the health officer's portfolio, none of these decisions are, again, made in vacuum. And so the criteria that would be used to determine, particularly in the setting where we see other jurisdictions closing schools and making significant closures at that level, is the information that there is no threshold, set threshold at this time to determine when we would make that decision, but those decisions would be influenced by clinical information, the epidemiology, the number of cases confirmed and suspicious, and also if there's any particular evidence of an outbreak in a particular location that might warrant closure at that time.
I just wanted to be clear for those who might not realize it, but the COMAR stands for the Code of Maryland Regulations.
Sorry about that. Used to talking in acronyms.
No, I know you.
Thank you.
And you do a very good job, but on that one, perhaps not everyone realized it.
Yes. For the reference. And before I shift over to Dr. Stoddard to talk about some of the structure of the county response, I do also want to make sure that people are aware of that we have this wonderful division within public health services called Public Health Emergency Preparedness. We have multiple playbooks that guide the work that we do, how we respond to outbreaks, how we determine who needs to go where they need to go, how they're going to get there. And the team has been planning for this. This is what we're trained for. This is what they do. This is what we do. So while I won't go into all of the specifics of what is engaged in that process, I do want to highlight the team here. They're behind me. And Sean O'Donnell is somewhere behind me. He oversees our FEPS team. And I can assure you that they have been working, engaging a host of different departments, from transportation, human resources, public schools, our hospitals, our safety net clinics, our other parts of HHS, including services to end and prevent homelessness for our shelters, licensing and regulatory services when talking about our nursing homes and long-term care facilities. So a lot of that work has gone into place, and even though it's not physically in the slide deck, I want to assure you that that work is being done.
Thank you, Dr. Gels. I have just a couple slides. I want to give you the overview of sort of how we're coordinating the response locally. Obviously, we are governed by our emergency operations plan, which was last approved in 2017. It gets updated annually, but last approved by the council in 2017. In that plan, we have emergency support functions that govern functional areas of response. Obviously, this falls underneath the Public Health and Medical Services, ESF, Emergency Support Function 8. And therefore, HHS is the lead for this response, but are supported by a whole host of county agencies as well as cooperating partners from non-governmental side, including our hospitals, Red Cross, and others. And so underneath that, we have a whole host of supporting activities that we do to either support HHS or also support county government's operations and ability to maintain continuity of operations throughout this response. Obviously, our employees are concerned and potentially at risk in the same way the public would be if this expands in Montgomery County or in Maryland, and so we need to be thinking about how we deal with those potential things should they arise. And so the Office of Emergency Management and Homeland Security maintains a COOP, Continuity of Operations Plan, and Continuity of Government, COG, plan for the county, and we do a whole host of things to make sure our departmental partners are keeping their plans up to date and are ready to enact them should it become necessary. Next slide, please. And so there are several key activities of our what we call the Emergency Management Group, which is a constellation of all of our partners across the county who help us respond. I want to highlight a couple of those key ones. And so public warning, this is actually our Alert Montgomery system. Underneath Alert Montgomery, there are a series of alerts associated called environmental and public health alerts. And the key thing I want to say about public warning side, and we'll talk about public information in a second, the distinction we draw between public warning and public information is if there's an action that we're asking the public to take, it will go out in combination with public information, but also through the alert system. So we do encourage people to sign up for the public health and environmental alerts underneath Alert Montgomery so that they can receive those critical notifications if we do see things that suggest that we change the way we're doing business in Montgomery County or things that we're asking the public to do in response that are very specific. We also do resource acquisition and tracking. So right now we are trying to get a handle on what personal protective equipment that we have in various departments throughout county government. Obviously, our goal in that is to understand exactly where we are placed to make sure that we can support, as Dr. Gale said, the healthcare workers, particularly our public health workers and our emergency medical services, to make sure that they have the equipment they need to continue to do their job throughout this entire response. We provide staffing support through the Emergency Management Group for a number of core public health activities, including points of dispensing, if we need to open those, should there become a vaccine available sometime in the future. Isolation and quarantine, either housing of people or enforcement of those orders. Dissemination of public information. We try and coordinate to the extent possible that everyone is following the same general has the same general knowledge and can disseminate, whether it's through you all through your council activities and to the public, through the county executive's office. We want to make sure everyone has the same information, can disseminate the same information broadly. Activation of the OC is included here, but the reality is putting people in a room together is probably not the way we will manage this incident for obvious reasons. We therefore have remote capabilities for almost all of our emergency management functions that we will utilize that include our web EOC, which is an online platform for management. We have a robust conference calling system and process for doing situation reports that does not require that we put people in a singular room. Next slide, please. And I just want to highlight a couple things that we've done for county readiness, both historically, but also very much more recently. And again, there are things that are missing here that I will update on. So we've been doing monthly COOP drills for years now. And so what we do in that process is have a specific section updated for all of our COOP leads every month. So those plans stay up to date over the course of a year. The entire plan gets updated. We have a tabletop focused on excessive absenteeism that we did that on January 9th before we even really knew that this virus was potentially going to be an issue. They say chance favors the prepared mind, and so we focused, we had an exercise with the chief administrative officers through COG, as well as the Emergency Preparedness Council at COG, to do a biologically based exercise both first in November and then obviously in December. So, we didn't know that coronavirus was a thing at that point, but we were already doing biologically based exercises at that point. Our first emergency management group message went on this in January 27th. We had begun to recognize that this was spreading internationally, and we wanted to be ahead of that. The WebEOC event was created on February 3rd. Public health was largely the primary agency, but also fire rescue. That's going to be expanded to other agencies as the need arises. As Dr. Gale said, we provided guidance to county employees on February 5th. We provided additional guidance to managers and supervisors on February 18th. And just yesterday, we provided additional guidance to department directors, particularly focused on the continuity of operations perspectives of this and how they can begin to plan with their COOP leads for potential absenteeism, or how we improve social distancing by doing staggered scheduling, increased use of telework, and other options like that. We are actually going to do an executive agency telework exercise, tabletop exercise on Thursday to make sure that we're ready to implement all the things that we've been planning to do for a number of years now. And so with that, I think we'll both be ready to entertain some questions.
Well, first off, thank you both very, very much. First of all, I guess all of us know more about COVID-19 in the last, and including you all, I guess, than we ever thought we would ever know. And of course, this was billed as the COVID-19 preparedness, and that's exactly what we need to be having that discussion. But it truly is comforting to know that both of you and many other people that you work with are in Montgomery County and making certain that we are as safe as we can possibly be. And of course, the part of the problems with this is the information and the misinformation and many times misinformation can go further than the information, and that's a huge concern, especially now because people will pick up their information or misinformation from social media, which really does not filter what is correct, and then they say, well, I read it somewhere. Well, yeah, you read it, and it wasn't correct. One of the things that I did here, and Dr. Gales was in my office the end of last week, and thank you for keeping us informed all along. I mean, it is very comforting that you do it this way, as well as Dr. Stoddard. I see him a little bit more often than I see Dr. Gales. But one of the things that I heard on the news was that people were concerned about, we get so many goods from China, and if someone bought a shirt and it was made in China, whether or not there's the possibility that they could be getting this virus from that. And it's my understanding, and in our discussion as well, that it doesn't live but a couple hours beyond on goods outside the body, and that's something that we really should not be concerned about. Would you like to talk about the accuracy of that, please?
Sure. There's no evidence or any data that has been released to suggest that we are at risk for utilizing any of the products that come from that region. So, there is no directive for folks other than to say continue business as usual, using the products, regardless of where they were manufactured.
And I did receive an email, a text, that someone asked about the cost of testing. If someone has insurance, I'm assuming that the insurance covers the cost of testing. I don't know how expensive it is, but that they cover the cost of testing. But what happens if someone doesn't have the insurance? How is that handled?
That is an excellent question. I think that what we're encouraging folks to do is that if they need the necessary treatment or they need the necessary testing to come through, and we will figure that out. I know that, for example, in the state of California, there is discussions about the state absorbing those costs. I know that Governor Cuomo in New York actually made a directive that all costs would be covered, so regardless of your ability to pay or your insurance status, that will be covered. And so what we want people to understand is to not let that be a deterrent. I think that's something we would figure out, because delaying the test could, one, have negative impacts on your health status, but also potentially increase the risk of exposing other people to it should it not be diagnosed. And I think that is one of the key things there's a clinical benefit to having a consult to talk about whether or not the test is needed, but I think that is also an additional layer to help make sure that those are getting tested truly do need it, and those resources that we do have are utilized for those who need it the most.
And I'm going to turn to my colleagues, but I did want to mention that one of their requirements, it's a requirement, not just something that we talk about, is to make certain that you and people who are working with you have the resources necessary to keep all of us safe, including yourselves. So please do not hesitate to let us know whatever you need. We are here to be of great assistance because you are certainly being great assistance to us. I'm going to turn first to Councilmember Albornoz, who's the chair of our Health and Human Services Committee, and then I'll turn to the rest of my colleagues.
Thank you, Mr. President. This originally was scheduled for our HHS committee, but really appreciate Nancy Navarro and a number of my colleagues who expressed interest in having a full council briefing, and really want to thank the council president for indulging us so rapidly. And both of you, I, as a former department head, participated in those tabletop exercises, and I know how comprehensive they are. And I was recalling last night that one of the last ones I participated in was a simulated pandemic event in Montgomery County. And so I feel confident that we have a very clear chain of command, we have very clear communication lines, and the constant coordination that's happening between our federal and state officials I know is ongoing, and hearing you articulate that this afternoon is very reassuring. I want to underscore the statements you made with regards to operating for the moment as business as usual. Until things reflect adjustments, we, as the governor said, and as you've heard repeatedly when there are other incidents, are hoping for the best but preparing for the worst. And I also want to acknowledge our colleagues and friends in Montgomery County Public Schools who have been very diligently tracking this issue. I wanted to just clarify a few things for the public. What phone number should people call if they have questions? Is there a number better than others? And specifically, we have received some constituent requests from people who have traveled abroad or have family members that have traveled abroad and may come back with flu-like symptoms, wanting to know where to go and what they should do and who they should contact. So if we could just start generally with the best phone numbers or people to contact if people have questions.
Sure. So that piece of that slide didn't change with the state recommendation. So that number is 240-777-1755, and that is to our disease control unit. And one of the things that our staff has worked on over the last week, and actually partly today, is bringing in volunteers from the Medical Volunteer Reserve Branch to come in and help staff the phones. We trained, I didn't train them, but our staff trained 6 individuals today to come in and help right away to help with the call volume. We've provided a script that is vetted based upon the most recent CDC guidelines in terms of being able to ask and triage to determine if individuals, based on, as you mentioned, who have travel histories, and even for those who may not have a travel history, since we're starting to see, community transmission, to be able to triage and direct them in the right places. So that is the number to call. And if it's after hours, it's still routed through a different number of resources. But ultimately, if there were questions that needed to be answered, a senior member of the staff would be notified. In addition, if at some point during that process, because we do recognize that call volume is high and an individual may not get through right away, or a call may not be returned right away, what we also are providing is the number to the State Department of Health, who could also provide additional assistance. And that number is 410-767-6700 during working hours, and 410-795-7365 after hours. So the thought is that if you can't get us, you can get the state, someone will be able to triage your information, and if it's a local case or concern, our staff will be notified one way or the other.
Thank you, Dr. Gill.
Can I ask you to repeat the numbers one more time? I didn't mean to interrupt, but one more time so that, yeah, all three.
All three. So the local health department disease control number is 240-777-1755. And the Maryland Department of Health numbers during working hours is 410-767-6700. And after hours, 410-795-7365.
And our operators at 311, I assume, have that information so they could make those same referrals for those same phone numbers, but to contact directly, those are the phone numbers. Is that correct?
Correct.
Right.
311 has a completely updated script for general information as well as the call numbers that need to go to. And also, I believe the information is also on the website that has been set up by HHS, montgomerycountymd.gov/coronavirus.
And will information be made available in multiple languages, just to make sure that people whom have English as a second language are able to communicate?
Yes, the staff is working with our OCA team and who oversees language access to figure out strategies to address exactly what you're saying.
Terrific. And while the cases remain low now, and we're tracking this in real time, as you mentioned in the beginning of your presentation, what, if you could give an example of, we've had SARS, we've had other diseases in the past. In your early estimation, Dr. Gales, you mentioned we're obviously still learning a lot about this particular strain, but has there been any discussion, particularly with the CDC, it's difficult to predict, but anything you can mention or comment on at this time? Is the rate of this, there was a slide earlier as far as where things stand right now as compared to measles and HIV and other viruses and diseases that are out there. But as this progresses, do you anticipate that changing, or is this where we are right now, and do you anticipate it growing at any higher rate than we see at the moment?
It's tricky to say. It's tough to say. And I'm cautious to say because, again, people will fixate on any information that comes out. But as evidence suggests, I think there are a couple of factors that will influence that number. I think the biggest thing is I think we have a fairly decent handle, or we're getting to the point where we have a better handle in terms of the number of individuals who are coming to the country. So folks coming here positive from other areas based upon the travel advisories and the travel restrictions that have been put into place. I think the component that we don't know about is this notion of community transmission. So the cases that were in Northern California and the cases in Kirkland, Washington, and the Seattle, Washington area were not tied to travel history or exposure to a high-risk or medium-risk person based upon their travel history. And so we have to, once we can get a better handle on that in terms of how the virus hung out, if you will, in the community, and how these folks were predisposed or came into contact with it, I think that will help guide the conversation around the reality of how many more people we expect, how many more cases we expect to see. I do think we will see more cases. I don't know necessarily how that will be geographically spread, because right now there's none in any other our region. I think the closest states are their cases. There's a case in New York. That case was tied to a travel history. I think there are 2 cases in Georgia that were tied to a travel history, and I think that there are 2 presumptive positive cases in Florida that were tied to a travel history as well. I think the closest cases that we have seen that are potentially community transmitted are in Illinois. From my understanding this morning, there's a patient at the University of Chicago who is concerned for a community transmission case. And so I say all that to say that right now, geographically, there's nothing close to us in terms of cases, and we don't have any cases that we know of at the moment. So it's hard to predict. So I say all that to say I think we will see an increase in cases in the U.S. Beyond that, I would be careful and cautious to speculate any further.
Thank you. That's very, very helpful.
I would add one thing. Just like we're seeing in Maryland, testing is going to become much more readily available, and that will likely just reveal some things that, about the nature of the disease in the community, particularly in Washington State and Northern California. And so the public shouldn't be, just because there's more testing, you're going to find what was already there. And actually, you'll be more effective in managing it once we have a better sense of the numbers in different places in the United States. So people's natural visceral reaction may be to be alarmed by an increase in cases, but they should also be somewhat comforted by the fact that we're actually getting better testing and getting a better handle on where those cases are, and we can better do investigations and isolation for those people who may have it. And so I would expect over the next week or a few weeks, we're going to see increases in the availability of testing, and that's naturally just going to have an impact on the number of people that we may see, not necessarily in Maryland or in this region, but in the country.
And my final question for now is, you mentioned there are some populations that are more vulnerable than others, particularly our older adult population. And what recommendations would you make to many of the facilities that we have in the county or our older adult population? Are there steps that they can take or should take to ensure their health and wellness?
Well, I think first and foremost, we just promote, the biggest thing is promoting just general health and wellness and making sure folks are taking care of themselves, getting rest, washing hands. It's not too late to get a flu vaccine if you haven't already. And I think we do have to have some conversations with some of those facilities that you mentioned to potentially talk about, visiting policies, things like that, should the numbers change. Because again, a lot of folks who are in those places are vulnerable, and we do need to potentially put in some practices that may be able to protect them. But again, those are conversations that I think, will continue to be had and discussed, and the level of action will be shaped by the numbers. And just to add one thing that Dr. Stoddard brought up is the other challenge with getting a sense of what the true case count is we've only been testing folks tied to travel history, so we don't know if there is a higher number of cases that, again, from the community transmitted population. And as we test more people and find out what that number is, again, I think you'll probably start to see a few more estimates in terms of the overall expectations.
I would only add that the one thing that we do have that we're very fortunate Montgomery County has is in our licensure and regulatory division of HHS. I know this because I was part of HHS before I took over as the emergency manager. I was actually in Sean O'Donnell's position as the public health emergency preparedness program director. We spent years when I was there, and this continues to today, doing emergency planning with our nursing homes as well. And so we should be comforted that in Montgomery County we actually directly license our nursing homes, and therefore they're required to have emergency plans, which we look at annually. And so we're actually a fair bit ahead of the game in terms of our work with our nursing homes than many other jurisdictions, certainly in Maryland and across the country.
Thank you both. And to underscore the Council President's point, it goes without saying, if there are additional resources needed, please, obviously, don't hesitate to reach out. This body is ready and fully prepared to support all of your efforts. Thank you.
Thank you. Dr. Gales, before I call on the next colleague, you said that something about it's not too late to get the flu vaccine.
It's not.
So does the flu vaccine that we have gotten, is that something that is of assistance?
So there is no science necessarily, no data to show that, getting the flu vaccine, or at least that I'm aware of, would mitigate, your COVID-19 infection. But given the epidemiologic data, you're more likely to come into contact with influenza than COVID-19. And so it adds an extra layer of protection for what you're more likely to encounter in the community. And similar, as Councilmember Albinos pointed out, is the folks who are vulnerable for COVID-19 infections or having more severe responses are the same folks that are vulnerable and at risk for having a severe response to influenza. So again, that goes to that notion of just general health and wellness and comprehensive care.
I would also add that our hospitals operate at a 90+% capacity during flu season because of that burden. And so whatever burden we can reduce on the healthcare system by getting vaccinated and preventing flu helps us have more resources available to treat and test people who may acquire in the future, not now, COVID-19.
Thank you very much. Councilmember Reamer.
Thank you. Thank you to the council president for convening today's discussion. That was a confidence-inspiring presentation. I want to thank the both of you for the work that you've been doing, the preparation that you bring to the job, and it shows the value of science and public health and emergency preparedness, and officials who have that expertise leading the messaging. So I really I am grateful for that. This is you mentioned this question about handshakes. I've had a number of fairly awkward interactions over the last few days as I'm trying to determine what to do. So we might as well be open about that. I feel like we should declare a moratorium on handshakes. That's okay. Let's, we can all understand that we're having that same thought process. Boom. That's how we're going to do it now. It's going to be I won't name it, but thank you. I think a simple message to that point is helpful. But a few reactions that I had from a sort of just an average person. The notion of stockpiling food. I know a lot of us are thinking about that. It was really helpful to learn that the reason to do that might be just as much, if not more, so that you don't have to leave if you or someone in your family gets the virus, as compared to you don't have to go to a grocery store where you might come into contact with it. That helps, because I'm sort of unclear. I hear reports from other countries, and it seems like to some extent people are still going out to the grocery store. I think it would be really hard not to go to the grocery store, but if I know it would really be beneficial to everyone else if me or someone in my family contracts it, then we should quarantine. Should you quarantine as a family if one member of your family is diagnosed with the virus?
So one of the things I didn't mention or kind of referenced and didn't go into detail is one of the most important parts of any infectious disease investigation, particularly in this setting, is the contact tracing. And so what happens is when there is an index case that has been identified, public health officials will investigate and determine who is a high-risk exposure or high-risk or medium risk, that kind of thing, based upon the level of contact, the type of contact, and the time and duration of exposure. So it is highly potentially likely that, for example, your significant other, child, someone gets sick in your household, that if you've had a significant amount of close contact with that person, you may be asked to quarantine for a period of time.
The doctors will explain that to you. You'll get a recommendation in the moment.
Yes, but you would be provided guidance as a part of that process. And this is similar to what we do, for example, in terms of a tuberculosis investigation. If there's an active case, those who are deemed to be high risk would get follow-up testing and follow-up to ensure they don't develop symptoms and potentially spread to other people.
Okay.
I would only add that there is a part of this assessment, there's a suitability for self-quarantine that's done by your provider or in concert with the county health department. Because if you are potentially exposed and you have an elderly parent living in your house, it may not be the best situation for you to quarantine with that person, but that assessment will be made in concert with your physician at the time and county health officer, county health department at the time if necessary.
Gotcha. Regarding testing, so if you are concerned that you might have been exposed or you feel like you're coming down with something, where should you go to get tested? Should you go to the hospital? Should you call your doctor? Are there testing centers? Are we going to be moving towards testing centers at some point?
Don't take this as an editorial comment. I think it's highly unclear as to the direction of testing. For example, we just literally found out today that the state will now be doing testing. I think at the federal level, they're still working out and figuring out how to increase access to testing.
Can I ask, but are you referring to what is done with a sample, like what lab actually analyzes it, or are you talking about where that person will go to when you say like the state will do testing?
Right. So there's two levels. So the state will run the labs, the test. So I can collect a test outside of the lab in Baltimore, but I would send those test results. There's a written protocol in terms of what samples, and by samples I'm meaning, is it a nasopharyngeal swab? Is it sputum that is expressed from the lung and collected? So there's a protocol in terms of what acceptable samples are, how to collect them, how to store them, and how to ship them to the lab. The lab in Baltimore will be the place to analyze all the tests, but the tests will be taken and gathered in the community. And so what we're recommending, and the state's actual recommendations and guidelines is that if you are concerned that you may have been exposed, we've provided you numbers to call and receive guidance in terms of your next steps, where you should go if you don't have a provider, if you should go to the hospital, or if you have a provider and you've had a conversation with your provider, who then calls and gets further guidance. Once that consultation happens, that'll either be with us and or the state to get that further guidance, to get the determination that you need that test. Your sample would be collected where you are, whether you're in the hospital or the provider's office. And one of the challenges, let me take a step back, one of the challenges is dependent upon, and I don't want to get too heavy in the science, but dependent upon the type of test that you are getting. So for example, if I'm expressing sputum from your lung, I need to do that in a control setting. I just can't do that here, because if I'm doing that, that could expose others in that area. So there's certain precautions. So you'd have to do that in a negative pressure room. And so you'd have to make sure you're in a facility that has the capabilities to do that. You as a layperson would receive that guidance and direction from us or the state to say, here's where you need to go to get that test sample drawn, and that sample would be sent to the state lab, who would then do the analysis and provide the result.
So I would call my doctor and say, I'm concerned I'm getting sick, and then they would actually refer me to you, to the county.
That call would happen, yes, so the call, those numbers I gave before would either come from you or your health provider.
Can we just say 311 and we don't need to worry about those other numbers, do we?
It's short. So we give people options because, again, we want to make
I've
sure
already
we get to the
forgotten
right
those other
places,
numbers.
so.
I know
Well,
everyone else.
you don't
Call
have
Sydney Katz. All right.
You don't have to forget them. They're part of the website, and so
Craig
people
Rice
can
knows the
access.
numbers. I'm going to call you, Craig.
So we want to make sure that we give people multiple avenues. Ultimately, they will be winnowed to, hopefully, the right places for the conversation. But I hope that gives you a bit more description and detail in terms of how the tests are done, who runs them, so on and so forth.
Okay, and then final question. So are our clinics, Montgomery Cares clinics, can you describe what their mandate are? Is HHS meeting with them? Are they now starting to get out to their community of patients? Because there's a large uninsured population. How's that going to, what's the procedure here?
So we engaged, again, going back to, so all health providers in the state have received updates similar to the updates I've provided by you all, have received updates from the Board of Physicians and the Board of Nursing and so forth. And so the providers at those respective places have been up to date in terms of what the guidelines are, the testing procedures. Back over a month ago, I mentioned we did engage specifically with CCACC, their clinic, as they reached out to us, and we had a forum to discuss with their providers in terms of what to do, and if you have a patient coming in, where to send them, and how to work through that. Secondarily from that is I sent out a communication. As I mentioned, we've communicated to a lot of different groups individually before the COOP planning recommendation came out, and they were one of them. So I sent a letter and communication to the executive directors of all of those clinics to kind of say, hey, here's where we are as a county, here's links to everything, here are the updated updated screening guidelines, as well as here are the updated testing procedures. And so they have been engaged on that level, and we have had some on a global level, and as I said, in addition to CCACC, we have talked at least to 2 or 3 of them on a one-on-one level, providing guidance in terms of where to send patients and how to conduct testing if needed.
Okay, thank you.
Thank you. Councilmember Jawando.
Thank you, Mr. President. And again, just want to echo my colleagues. Thank you all for being here and for the comprehensive update and work that we're doing. I know we're ahead of many people. Just to follow up on one of the first slides was the where we stand, and just so, I don't know if we still have it up, but you had at the top, I understood it to be national numbers,
Yes.
and then at the bottom were Maryland-specific numbers, realizing there is no confirmed case in Maryland, but that there were 6 tests, 5 of which came up negative, 1 of which we're waiting on confirmation. Is that, am I reading that
It's now
correctly?
8 tests.
It's now 8 tests, that's what you
And
updated.
3 are
Pending.
Yes.
So, okay, so 5 negative, 3 pending, and at some point, you'll get that information, and that'll be updated.
Yes.
I think that, I was poking around your website, and I know at the top, at our website, it's not yours, our website, the county website, and it says that there are no current cases, but I think that's something that I hear a lot is like, just while I was here saying that we had an update, I'm like, what, can you send that, Maryland? Are there any, that's what people want to know, and I know it cuts both ways as the testing improves, but I would just say that to the extent that everyone can be kept abreast of, as that increases, we know it will, the number of tests and the number of.
There's also a
results.
great deal of confusion about Washington State and Washington, D.C.
Sure.
And we need to be very clear and explicit about that, our neighbors to the south do not have any confirmed cases either.
Right.
Washington State, obviously, there are, some number of community cases that need to be, worked at.
Right. No, I appreciate that. So I would just, great. That's great. And I think as that, maybe, I know this will be a work in progress, this site as well, because you had to get it up quickly. To Councilmember Reamer's line of questioning, another thing that I'm hearing, and I have concern myself, you cleared some of it up. If I feel sick, step 1, what do I do? And at the bottom of our page, it says call your provider, or it says see your primary provider, and then it says call ahead. Just as far as the mechanics of, do I physically go to the doctor or the hospital? Because if I don't have a doctor, do I show up at the hospital? I had a couple of nurse and doctor friends saying that just today they got their screening algorithms at the hospitals locally. So this is all happening in real time. What is the best guidance we can give? I'm coughing. I suspect that I've been in contact with someone from overseas. What do I do? What's the first step? I call the doctor, or I call the hospital. If I don't have a doctor, could you go through either one of those scenarios? What do you think is the best step to take?
Well, I think the first and foremost is seek medical attention as needed, as cliche as that sounds. And then within that, if you do have a primary care provider, engaging them in a conversation, because they can help, again, determine, based upon getting more of a history, if you are at risk for this versus this is the flu or something else and you don't need to worry about this. And
they can do a screening.
They can do a screening within that. If that is not available, I think, there are a host of other ways to interface within the medical community. That is going to the emergency room, going to urgent care, those kinds of things. The reason why it was suggested that folks call ahead is because providers did have the concern if you were showing up and if you did have symptoms, you could expose people to other things. And so that's why it's recommended that you call ahead.
So call ahead first, whether it's the doctor, your doctor, or the 311 or the 240-777-1755. Call ahead.
That would be preferred.
That's what I was hoping to hear. Call ahead.
Call ahead.
Okay.
We do know that, not everybody does that. May just say, I'm not feeling well, I'm going directly to the emergency room, and that will be dealt with in that setting. But in a preferred setting, you would have a conversation, because then that could help elicit more of a detailed history to determine kind of which direction you need to go into.
Great. No, I appreciate that. And then the last question, I know others have questions. Are you coordinating with the hospitals and as they've developed their algorithms and they're on the same page, and is there communication lines locally for our county hospitals, for example?
Yes.
Okay. And you mentioned signing up for alerts. Could you give I think you mentioned that, Mr. Doctor.
Yeah.
Where do you do that?
So right from the county web, you can go right to the county website, goes alert at montgomerycountymd.gov. They'll take you to the sign-up page. Once you get into there's a section called Government Alerts. It's a checkbox that you can click. One says Environmental and Public Health Alerts. You want to make sure that box is checked. If you have any concerns, if you already have an account and you're not sure whether you're signed up for that, you can call 311. You'll get directed to the Office of Emergency Management and Homeland Security, and we'll help you work through it.
Okay, that was going to be my other suggestion. If we could maybe if there's a way to quick link on the site, here's how you sign up for alert. That was like 3 or 4 steps that I'm not sure I followed.
Yeah, so there's multiple options. So if you want to call 311, that's very easy to do. Okay. Or you want to go to alert alert instead of www, alert.montgomerycountymd.gov. It's right there.
Okay. Thank you all for your work. I appreciate it.
Thank you. Councilmember Glaius.
Thank you, Mr. President. Also, thanks to the HHS Chair, Mr. Albornoz, for organizing this conversation. And I'm pleased to see everybody who's here. And I know that there are many others who are following online, because this is a really important conversation and people are legitimately concerned. And that's why we're having this conversation. And then there are thousands, I would say, of our neighbors who are engaged in this as well. Thousands of our neighbors who work at FDA and are helping make respirators more available where they're needed, and also helping update their policies to move this process along so that we stop any spread. Neighbors who are at NIH, where clinical trials are already underway. And then also here in Montgomery County, we have the Association of the Public Health Laboratories, which is coordinating nationwide all the different labs that are undertaking this important work, testing and other types of analysis. And so I'm heartened to know that Montgomery County is in the middle of this, in the middle of helping stem this problem. I don't want to use any other words to describe it because we're not there just yet, but it is an all hands on deck, and I'm comforted by the fact that we are working to make our community healthier, to make our country and ultimately make the world healthier. And so towards that goal of trying to keep people healthy, here in Montgomery County we have a very robust healthcare network, many of whom are nonprofit providers, helping those who are quite vulnerable. And so my question is, how do we help the providers if they see anybody who's in their care who don't have primary care doctors, who don't have insurance, who in some instances lack transportation and lack any other networks? And so how can our social safety net remain strong in the face of any problems?
I didn't see you rush to answer that. Well, I think first and foremost, as I mentioned, we've engaged with them in conversation to talk through those issues and have prioritized providing assistance. So again, I mentioned and referenced the notion that we sent communication to numerous agencies with homework assignments in terms of planning, and that's been part of that conversation discussion to find out exactly, what is the depth and level of those needs. So, for example, if transportation is an issue, similarly, we have engaged the Department of Transportation to put on their radar, potentially would we be able to use, public transit resources to be able to transport patients back and forth from clinics to hospitals and health centers to get that type of care? So those are the kinds of questions that we've been asking and have been very, very thoughtfully considered and continue to be considered by different agencies. And going back to the example of CCACC, part of their big need was engaging their community and addressing a lot of fears that folks had and questions. And so, we worked with them to talk through a lot of those questions and issues. And I think, it's an ongoing conversation in terms of, again, developing an understanding of what the true needs are. We have helped, at least in 2 instances, inform, before the most recent guidelines came from the state, but inform the clinical algorithms in terms of where patients should go and how they should interface with the healthcare system outside of the safety net. I want to emphasize this is why it's important to reach out and utilize the health department and the state as consultation, again, to help be able to differentiate cases that do need further workup in the direction of COVID-19 versus others. And so going back to that notion of helping inform those clinical algorithms, I personally had some conversations with some of the clinical providers to talk through some of the cases to help determine which direction they should go in terms of those histories. So I think those are some examples of where we are right now. The conversation is fluid. And the great thing about it is we have engaged other agencies that would potentially be able to step in and help address those, for lack of a better term, social determinants of health that are impacting or could potentially impact a client of those particular clinics ability to be able to move forward and get successful care.
I would only add that our oldest social safety net, or one of them, the 911 system, is we've been working through that as well to make sure our EMS providers are prepared to respond to people who just call 911. That is absolutely still a resource that can be utilized if people experience severe illness. We want to make sure that we're going to make sure we catch people potentially who may ultimately, eventually, not now, have the coronavirus, and make sure our EMS providers are prepared to respond to those people, transport them safely, decontaminate their units if necessary, and get them back in service as quickly as possible. I know there have been a number of first responders in the Seattle area, particularly associated with the nursing home outbreak, where they've had to have, I believe, 25 of their first responders put into self-quarantine, which obviously is a huge problem for their EMS system. And so we're also working through those challenges, too, to try and prevent that kind of situation from happening in Montgomery County. Our desire is not to have to take units out of service because of a transport, if it ultimately happens, for this coronavirus, and to make sure that we have a robust system in place to keep that operational and churn through, transport, decontaminate, and get back in service those units when necessary.
I appreciate the thoughtful response, because when I was speaking about the lack of transportation, I was actually alluding to possible mobile responses, right? Whether it's DHHS or any of our other agencies, but to know that the level of conversation, the deepness of that conversation is extended to even the Department of Transportation, utilizing those services. I'm heartened to hear that. And then last question I have, can you talk a little bit about the team that is working through all of these issues? You had mentioned various phone calls or conversations with the feds and with the state, but who are helping make some of these conversations and the coordination effort here in the county?
I'll try and give as succinct answer as possible. And so that we have regional conversations between health officers and emergency managers through the National Capital Region. We've had statewide emergency manager and health officer calls for the state of Maryland. Certainly, we've had some conversations that have been, I think, jointly between HHS, federal, CDC, the state, and local health officers. In Montgomery County, we've had a robust series of calls that have largely centered around our emergency management group. Those are going to continue weekly on Friday afternoons for as long as this takes. And those are meant largely to make sure everyone's on the same page on a weekly basis, that we're addressing concerns that come up in one meeting to another. The school system are a part of those conversations. Our emergency management group is loosely defined as the 100 plus agencies, organizations, or other partners who are part of our routine responses. They include all of the county government executive agencies, principal and non-principal offices. We're working with the Board of Elections to think about our primary on April 28th. We're looking at our transportation. What about our ride-on bus service? What happens with that? We're looking at how we can make sure, can we do alternate shift scheduling in county offices to keep our essential services continuing for as long as possible? How do we deal with our libraries and rec centers, which are very front-facing, have routine public interface, and for whom we have already heard a number of concerns? How do we continue to operate those safely? All of those partners are involved in these calls to make sure that we're trying to consider every possible iteration of every concern that we can see. We've got two people sitting up here, but we're representing hundreds of county, state, federal, nonprofit. I know you mentioned some of the people working. We also have biotech industries in Montgomery County working on vaccines, so it's the private sector is involved as well. And so it is a broad constellation. I could sit here for an hour listing off partners. I won't, but just understand that we have a very broad cadre of folks working on this issue regularly.
Thank you for that. The more people who are at the table, clearly, the better prepared we are.
100% agree.
And that is a sentiment that I just heard from you. So, without taking too much more of your time, aside from the time it took to make this presentation and the few hours that you're with us, I appreciate it, because I know you'll be back on the phones, back on the emails, trying to keep our community safe. So thank you for all you're doing.
Thank you. Councilmember Rice.
Thank you very much, Mr. President. I'm going to try and be brief. I've heard conflicting information about vaccines and timing of how long it would take for a vaccine. I've heard local companies that are here in Montgomery County who have espoused that they're close. There's been a whole bunch of misinformation that comes about regardless of, where things are. Can we shed some light on that? Because a lot of the public's looking to that. So as we are dispelling myths, can we talk about some of that, Dr. Gales?
I'm being very careful not to make any editorial comments about anything and speak strictly from the science. So a couple of things. I actually wanted to make one addition to Councilmember Glass's comment and to Dr. Stotter's comment, is we have actively engaged the county executive's office as well and his team, and we have provided multiple briefs to him and the CAO's office and their team, so they are up to date and have been a part of the conversations ongoing. As it relates to the science of things, so there's a couple layers. There's the conversation around vaccines as well as a comparable conversation about therapeutic agents for it. I'll address the therapeutic agent component first because I think it's a little bit less controversial in terms of that. So there have been a host of agents that have been discussed as potential options to provide remediation of symptoms for COVID-19. They exist at large, a different set of levels and trials. So, and I think I'm pronouncing this correctly, Demesivir is a drug that was developed, it is an antiretroviral that was developed to potentially combat SARS. And it is being studied now in animal models to see if it's effective against COVID-19. And I think there are a host of other drugs that fall into the antiretroviral category that have historically been used for other viral illnesses that are being checked out to see if there's any efficacy in terms of treating COVID-19, including Tamiflu, I think lopinavir, ritonavir, I think are two others. But again, drugs that have other purposes that are being studied for this particular treatment. As it relates to a vaccine, there is conflicting information because one of the things, even as science develops and moves forward, the question is what will the regulatory responsibilities and needs be in terms of moving those things through the process. The reality is those things take time. And so the question is how quickly will those be available? I think the verdict is out. If it operates through a traditional system, it could take some time. And when I say some time, we're talking on the magnitude of a year or multiple years within that. So I think there are lots of different pieces of the conversation that need to be had in addition to the developing the scientific efficacy of it, as well as the regulatory aspects of it and moving forward. What I would say is, from our perspective, we are operating under the assumption that that won't be something that is available anytime soon, and not banking our response on a vaccine being available. And that is not meant to comment on whether it comes tomorrow or not, but just we're planning in the event that that is not an option as part of our toolkit.
And I just have one more question for you, and then I'm going to ask whoever is going to be representing our school system if they could come forward, because my next and last question will be for them. But Dr. Gales, when it comes to, you had mentioned at the very beginning about a healthy individual may present with having the COVID-19 virus, but then still be just fine and end up over the course of time just not having any other sorts of challenges and then present as fine in a week's time. But during that same time, they're also contagious, correct? And so they could then spread their COVID-19 to other individuals. And so from that perspective, I'm just curious about whether you're a healthy individual or a non-healthy individual, if you have the symptoms, about the urgency in getting or seeking some sort of advice, understanding that many of us come in contact with many people. I mean, I'm not trying to, scare anyone, but I was just at a NACO conference with individuals who were from Washington State. Now, they were here, so they weren't there, but it's just one of those things where, again, we don't think about all the different levels of which there's that ability and interaction that's there. So from that perspective, just talk very briefly about the vigilance that's required in terms of, or if there needs to be, in terms of a person who typically may be healthy, who still may have some of the symptoms, and what their responsibility should be should they present with some of these symptoms?
Sure. Well, I think this is important and goes back to utilizing your healthcare provider and getting more contact, consulting with the health department so that we're able to identify folks. And, you know, even though you may be feeling fine, we can identify you, give the appropriate testing and identify you if you are a true case, and then do the necessary contact tracing and follow-up for you doing the quarantine process, those kind of things to mitigate it. What I was specifically referring to in terms of the healthy status, though, was more so in the perspective of if you do get sick with it, you are likely to have a convalescent period where you are ill for a number of days, but your response will be fine. You will rebound and you will be okay and you will go back to normal. That is not consistent across the board in terms of for individuals who aren't otherwise healthy. Gotcha. And those are the folks who are at risk. For example, I know at least 2 of the deaths in Washington. I can't speak for all 6 because I haven't had a chance to go back and look at the newest 4 cases, fatalities, is that for 2 of the individuals, the first 2, they were individuals who were not in a good state of health from a chronic and an acute standpoint. And so that is the concern that, you know, for individuals in those states, and I think they're residents of long-term care facilities, and so they had complicated medical histories that predisposed them to having an adverse outcome after contracting the virus. So just wanted to make that distinction within that. But certainly we would encourage, that's why the providers need to talk with the health departments to get that guidance, to do the necessary testing so that we can categorize folks appropriately.
So my question for our school system, and we've seen across the country a number of school systems reacting in different ways to the potential in terms of some sort of outbreak or spread of corona in school systems. Some have been as bold as to start purchasing laptops for all of their students in case they had to shut down schools. Some have already shut down schools in Washington State in jurisdictions and said that they're, you know, responding with the biggest kind of prevention methodology they could. What's the plan for the school system, and should we have a case that's in the school system? What is our level of preparation? What is our plan in terms of ensuring that education still goes on? Are we adequately prepared, and do we have the proper tools necessary to be able to continue without any sort of major disruption?
Okay. Good afternoon, County Council members. I'm Monifa McKnight, Deputy Superintendent for Montgomery County Public Schools. I am joined here at the table with our Board President, Ms. Deborah Evans. And thank you so much for raising that question, Councilmember Rice. We have, as Dr. Gale said, very much been setting up a command center and MCPS and following and working with our partners every day to just figure out what is it that we do. And so I'll just start by saying, first and foremost, we are committed to providing a healthy and safe environment for our 166,000 students. That is our priority, has always been our priority, and we will continue to focus on that. And so how do we do that? We have been working in collaboration with the Department of Health and Human Services, as Dr. Gales mentioned, from the beginning of this, and really working to monitor the situation to, one, make sure that we can provide timely updates to our community, because as you said, there are changes that are happening every day, and as people watch the news, things are happening across the nation that we have to be aware of. So a few things that we've done, and I'll reference Councilmember President Katz earlier when he mentioned the importance of putting out the right information. So we have been very focused on doing that. And so in MCPS, we've created a web page of information with the links to resources, facts to remind people of what's happening. We're updating new information as information comes out. And we make sure this information is available in multiple languages to make sure there are no barriers for parents who are trying to access current and new information as it relates to this challenge. We are also sharing information on social media platforms, as well as using our traditional media sources as well, just to make sure we're not missing anyone in getting that accurate information that's being shared. And we've heard definitely concerns from our parent community, just wondering, you know, what will we do about the spread of this virus if that occurs? And so I just want to say, as Dr. Gale stated earlier, The Department of Health and Human Services will make the determination if we ever get to the point where a school closure is necessary. So I just want to make sure that people understand that this is a very collaborative effort, and so we are working with the Department of Human Health and Services. And so at this point, I'll just say, based on their information and from a clinical standpoint, we are in a good position right now in Montgomery County Public Schools. So with that, our schools will remain open. I know that's been a question for people, and so our schools are remaining open, and we're continuing, again, to share the critical information that every family needs to know that will keep them updated. So instruction continues to be a focus in Montgomery County Public Schools, but with that, I'll say that should the situation change, our goal is to make sure that we are staying close to the information, and our commitment is that we will be in immediate contact with our community members so that they know if any change occurs, we are going to be proactive in making sure we put information out to our community to say exactly what we will do and what we will do to address a particular situation that we're facing at that time. So we'll continue to participate in the tabletop activities with the Department of Health and Human Services. They mentioned earlier, we have staff who participate in those exercises and again, speak about how real and important it is to go through those exercises to really say if we ever get into the situation, what exactly is it that we do. And so with that, I'll just say that we have been very thoughtful about what do we do in the short term right now, and if we get to a situation, what do we do in the long term? And so we are having the conversations about, one, making sure our facilities are clean. That's the focus that we always have every single day. Now we've taken that to the next step and really talking about how can we be very proactive in taking preventative steps to make sure everyone's in a clean and safety environment. And so our building services staff, they've been really focusing on having an increased focus on disinfecting all of the communal services as a part of our action plan. We're continuing to make hand sanitizer available as we always have. However, we are emphasizing the importance of making sure that people participate in thorough hand washing and use soap when they are available to do that. And in that part, I also want to say, we know that attendance is very important. We understand that. But we also want to note that if our students are sick, they should stay home. And I mean, that would be the case if we were talking about the flu or anything else. So those are just healthy habits that we are emphasizing in our community. Again, attendance is really important. But if your child is sick, we want them to stay at home so that they can be cared for and so that we don't run the risk of sharing. So those are some things that we're doing, and of course, if we get to that point, we're ready to talk about information that or steps that we've taken to plan for instructional activities. If we get into a situation and we actually have to face a closure, we're having those conversations about what do we do to make sure we utilize the current resources we have. Like, for instance, all of our students have a Google account for education, and so we would look at resources like that to utilize. And then for our families who we want to be able to meet all of our families' needs, and so we'll make sure there are also activities that are provided in a hard copy if that's needed, and working with the community to do so. And so we have a number of web-based resources that we rely on, our ITV broadcasting educational program that we have, utilizing resources like that. So again, we are now planning for the immediate, short-term and long-term.
Yeah, well, I really appreciate that, and as a parent, I know all too well about how everything's on Google Classroom. I can actually follow my daughter's syllabus day to day and know exactly what she's studying, what the homework was, all of those kinds of things. And so I really want to applaud, because I think that the efforts that MCPS has done just in terms of parental involvement and inclusion has actually resulted in us being very prepared when it comes to something like this. I know that even your investment when it came to additional Chromebooks for students who need them, who may not have devices at home, all of those kinds of things are really coming into play now and putting us in a positive position when it comes to hopefully there won't be, but should there be an incident, that I think that our school system is aptly prepared to be able to deal with something like that. So thank you very much, Mr. President. I appreciate it. Thank you.
Can I add one more point
Dr.
to what you were just saying? There are a number of practices that we have in place in Montgomery County Public Schools that, if needed, they won't be new processes. And I'll say, for instance, if we got to a point and we actually had to talk about a closing, we're prepared to serve meals at regional sites because that's what we already do. That plan has already been in place, and that plan has been in place through inclement weather, summer meal programs, and so a number of things that we actually have in place. We've had practice through many of those venues, and so those are things that, again, we will just put into place at the time if needed. Thank you.
Thank you. Councilmember Friedson.
Thank you, Council President, for organizing this. Thank you as well to our HHS Chair, Councilmember Albornoz, for putting this forward, and for Councilmember Navarro, not only for working together with you, Council President, to move this to a full council session or suggest it, but also to lead by example that when you're feeling sick, you should stay home. So we appreciate that. And since I believe she's one of the million watching at home, thank you, Councilmember Navarro, for leading by example in that regard. This has been a really helpful exercise. So I really do appreciate that we did this as a full council, that we elevated it to generate additional interest in it and knowledge of it. And I think the extra day as well helped for folks to realize that it was happening. It's been really telling for me personally, but I think it's been really helpful, more importantly, to the public. I think all of us have been hearing regular communication, casually and formally, to our offices. I can tell you, even recently, I was at a Strathmore board meeting, and this was a topic of conversation as an organization of what should or shouldn't happen, and how to keep business as usual but take the necessary precautions. And that's just one of hundreds or more organizations that have large gatherings that have to be grappling with these really difficult, challenging, confusing questions that are before us as the national media and the local media takes on these important issues, and that understandably causes some concern. I think the balance that we have and that you've demonstrated here is providing an appropriate level of communication and sufficient information so that we can be prepared as a county, and so that we can be prepared as a school system, and allowing our residents, our businesses, our community-based partners and health providers to be prepared as well, but not allowing it to get to the point where it creates additional panic, additional concern, and unnecessary pause in our community. Because as we've heard here today, the best thing that you could do, it seems to me, is to exercise healthy habits, as we should be doing anyway, washing hands, staying home if we're not feeling well, and just taking necessary precautions and taking care of ourselves. And I think that that's an important message that we ought to share. And I think the other thing that's really clear and confidence building for me is that, as was just stated, these aren't new procedures. We're deploying existing procedures, and it feels like we are prepared. And I think that is a really important message that I hope that our residents are aware of, that this isn't something that we weren't ready for. This is something that we are ready for. And while it is a quickly evolving challenge in a public health crisis internationally, and the data might be changing and the individual circumstances may be changing, the policies and procedures and the systems that are in place, we're ready for it. And I think that is a really helpful and a really important point that I just want to make sure that everybody understands as we get lost a little bit in the details, the important questions that have been raised. I just had a couple questions. One is, it was mentioned earlier, I appreciate it. I had heard Secretary Neal mentioning the testing of the screenings in Baltimore, and that being a major development. The governor also mentioned that. You highlighted that here. Could you explain, is that something that is normal? Is that something that most states do? Is that different? Is Maryland different than other places in being set up to do that? And could you explain what impact that has in terms of the timing of results, or what the practical implication of us testing it versus sending it to the CDC?
Sure. So if you recall back to our COMAR regulations, the Code of Maryland Regulations that I shared with you, it also lists a host of communicable diseases, a full spectrum of them that are reportable to the state, and the state laboratory has the capacity to test for those different conditions. And so by having the access to the state lab, it's significant because it makes it easier to transport the specimen. You know, Baltimore is 45 minutes away. And it also cuts down on the time period within which we have to wait for results. So you can imagine in a setting where there is a patient who has a condition that is potentially responsive or needs a particular treatment, how that delay in getting a diagnosis may complicate that picture. So as it relates to COVID-19, it will cut down on that window because, as I mentioned, the average wait time for getting results was approximately 72 hours, which is 3 days. And so it shortens that window, and in particular, it has a significant impact in the ability to more quickly do contact tracing if a case were to be identified. Is you're not waiting for 72 hours for a confirmation. You can get that confirmation much quicker and start that process with more information.
Great, that's helpful.
And I would just add to that, and if you remember the original window that Dr. Gales talked about for symptomology, 2 days to 14 days, if you can identify the positive cases before the 2-day mark, you may be able to prevent them from ever potentially exposing other people. So that time should not be. That is a really important point to underscore. We can actually catch other potential contacts before before the person may be infected.
And do you know if that's a regular circumstance in other states, or is that not something?
All the states are working to get up to do this right now. I don't know what the total number is. We're seeing new states come on with this capability every day at this point. And that's why I think testing is going to become robust nationally. There's been some controversy about the CDC removing its test numbers off the website. I think that's largely driven by the fact that it's now so decentralized with a number of states doing it that those numbers are hard to collect. I think for good reason the pressure should be on them to still post those numbers. But
the goal is to decentralize it, to reduce the time frame
exactly.
in order to get it within the 48-hour window, ideally.
Exactly.
To reduce the risk. That makes sense. So I mentioned earlier the large community-based organizations. Besides the standard order business, as we talked about before, are there any other additional advice or any suggestions? I mean, a lot of the conversation earlier was about individuals and what they should be doing in order to prepare. I mean, obviously, there are policies and procedures that many large organizations have in place, hopefully for pandemics or others. But in the absence of that, or in addition to that, are there any other aspects of advice different from individuals that you would suggest to organizations of things that they should be doing now to prepare should this get worse, which we hope it doesn't?
Sure. So certainly what we see with business continuity is often business continuity in most cases focuses on loss of facility or loss of infrastructure. There are certainly personnel considerations, but those are what I think will be almost more important in this particular kind of scenario, where you have to think about how do you increase social distancing in our workplaces. And so obviously any policy that you need to put in place that discourages sick people from coming in, for example, if people haven't accrued enough leave, you offer programs that allow them to take either advanced leave or administrative leave to make sure that they're not coming in sick because they do not have the sick time to take. The examples like that. If you have opportunities where you can decrease or increase social distancing techniques within your workplace, canceling. If you have an office huddle on a weekly basis, turn that into a Skype or teleconference opportunity as opposed to putting everyone in the same room at the same time. Things like that are what we're going to expect to have to implement once or if we see community cases. So those are the things that people should be talking about now to make sure that they can get the infrastructure or capability in place to do that and just work through the policies of how that'll work.
But the recommendation is to be prepared to put that in place, not that they need to be put in place
We're
today.
doing nothing right now.
Okay.
But it is all about...
Look at all of your procedures and say, okay, you have a normal weekly staff meeting. Be ready to do that as a remote meeting if possible, should the need arise, but not now.
This is a lot like a hurricane, right? So we actually have opportunity where we know the storm hasn't hit yet, but we know it could be coming. So we take the opportunity now to put things in place that make it easier for us to respond once and if we do.
And presumably for additional teleworking and others within county government, that those plans have been put in place or are in the process of being put in place?
We are looking, the OHR Director, Burke Attila, sent us an advanced telework policy procedure this afternoon, and so absolutely there are things moving on that front, yes.
So if anything like that becomes available, once it's ready, if you could send it over to us, I mean, I think it'd be helpful for us to know what the county government is putting into place to be prepared for this. I don't want to be clear that we're talking about things that may be needed, but
and we
currently
did
aren't
extend,
needed.
we are having this exercise on Thursday. It's continuity of operations focus. We did send an invitation to Ms. Michelson this afternoon or this morning. So if she hasn't seen it yet, she'll certainly see it. So we do want to include council in those conversations. We'll certainly share any policies, procedures that we develop on our side.
Appreciate it. And I think we all recognize that this is an evolving process, and so we just appreciate the constant communication. Earlier was mentioned communication with hospitals, which I appreciate. How about other health organizations that are smaller than hospitals, a small health clinic, an individual doctor? Are we set up to be communicating with them so that they have the similar type of communication of best practices as this thing evolves as the hospitals are?
So the short and long answer are yes. We have engaged, as I mentioned, we've engaged the hospitals and the larger health systems, and we've directly engaged the safety net clinics that are part of our county system and provide services in other areas. In addition to that, from the state level, there's multiple layers of communication. Anyone who is a licensed healthcare provider is getting these regular updates from the state. So I, as a licensed physician in Maryland, get an update from the Board of Physicians when these things come out, in addition to what I get as a health officer. So there's multiple layers of communication throughout the different networks. We don't necessarily have within public health services an extended network to contact everyone individually.
But they're getting that from the state.
They're getting it from the state, and also, for example, there's other avenues. For example, the County Medical Society is an avenue to be able to put out information as well to local providers who are members of it. So they're
And the
getting
same true
information
for
from
assisted
somewhere.
living and other older adult population centers in addition to full-on nursing homes?
So for nursing homes, should be getting communication from the state as well, but that is one of the priority areas that we are working on to directly communicate. As Dr. Stoddard mentioned before, we're one of the few jurisdictions, I'm not sure, I think we may be the only jurisdiction in the state who actually does licensing of those facilities at the local level. So we have relationships with those facilities. Our licensing and regulatory staff has begun working on communicating and working with them directly. That is also a part of the HHS COOP plan in terms of building on those relationships, as he mentioned before already. We go through, and as part of their yearly review, we review their emergency preparedness plan. So there will be multiple layers of communication with them, building upon what we already do, regardless of the current situation.
Great. And specifically for some of our more vulnerable populations, in addition to the aging adults, how about the homeless population? I see the Coalition for the Homeless this year, Progress Place, some of the other organizations, Bethesda Cares, Every Mind, that are interacting on a regular basis with these organizations. Is there a particular protocol or way that we're addressing that to make sure that they're being helped to get, identify any symptoms and get the testing and treatment that is necessary?
Yes and yes. The first yes relates to we have provided direct guidance to staff from our services to end and prevent homelessness to share with the shelter community. In addition to that, again, as part of the HHS COOP plan, that is a priority population that has been identified to make sure that the current protocols are reviewed and that we discuss ways to enhance that communication and outreach. So again, similarly to Councilmember Glass's point about safety net clinics, creating a two-way conversation so that we have a better understanding of those exact needs so that we can meet those as part of the planning process.
Great, thank you.
And I would add that we are, just because you didn't mention it, but the Montgomery County Correctional Facilities, we're doing the same kind of work. It's a similarly potentially vulnerable population, and so I did want to extend that we are also doing that planning as well.
I appreciate it. Thank you. I will just reiterate the point that Councilmember Albernaz made about how we are here, ready, willing, able, and obligated to support you in addressing any health issue that could evolve into a health crisis. And, I'm hopeful, specifically as the question was asked before about the cost of the testing, that if there's a way for us to formally request that the state bear those costs, as many other states are doing, I think we should do that. And so I hope that we can work together on that. And if need be, the county be willing to step up in the interim until we hear back from the state to just make sure that there isn't anybody in our community that doesn't get the testing that they need, or any healthcare provider that is put out by providing what are the resources that we need to solve this challenge before us. Thank you.
Thank you. Two things. First off, for the areas where there's, and we have one more council member that's going to speak, the areas where there's a large population of older adults, as an example, Leisure World and other places, are we communicating with them at all?
Yes. So our aging and disability team has had conversations, discussions with them, and reported, particular concerns that we are working to address. And in fact, I believe on next Wednesday there will be a public session there.
Absolutely.
Right,
it's a senior town hall meeting.
Senior town hall meeting, and I will be coming with our aging and disability team to be able to address any questions that folks have. I anticipate that between now and then there will be more focused conversations and discussions with them as part of our team continues their outreach.
Thank you. Actually, thank you for anticipating that, because I was going to ask you after this if your calendar was available. But go ahead.
If there are other opportunities like that that you think would be beneficial for Dr. Gales or I to come, or members of our respective teams, we're happy to do so.
And one other thing, and then I want to ask my Vice President Hucker to speak, but is it possible to have these slides that you presented today on our website? Or is there one? Yes? Okay, because we're very good. We will do that. And the last person to speak this evening is Vice President Hucker.
Quite a build-up. Thank you. Thank you all for everything you've done to date. Counting on you to make sure we're prepared. Are there any funds or other support that you feel like you need that you don't already have?
I think the best way to answer that is, I know our team is working in terms of doing looking at what resources we have. We've communicated that to the state in a number of areas. I think we could communicate some, in terms of they've asked, what are our resources, what are our supplies. I think we could have a conversation after this, after we have a better understanding of where we sit, after we've completed that review.
Okay. I will also add that FEMA has given us notice that they will actually be allowing certain of our, particularly emergency management, homeland security related grants, to be expended towards coronavirus response. Typically, they don't give that dispensation, so that will allow us some grant flexibility to redirect things that would have been done. For example, we would normally be doing a county functional exercise in our emergency operations center at the end of April. I don't think that's a particularly prudent thing for me to be planning at this point, and so we can redirect resources that would have gone towards that exercise towards this coronavirus response.
Please keep us posted, and don't always feel the need to run everything through the usual channels and wait for an answer. You all know how to reach us. You sent a letter to HHS employees and county employees on February 5th. I don't think I got one. Would you mind sharing that with us? And any of the other directives toward staff about the precautions they should be taking, whether they should be staying home if they experience any symptoms, how to seek treatment. Is there any direction to managers about what guidance to give to employees, when to stay home, when to telework?
Yeah, we issued that, I think, on February 18th, I believe. I think we provided all members of the council with access to a SharePoint that actually has all of those documents on there. But to just go over sort of largely what they focused on, if people are asked to self-quarantine and they don't, the executive branch is going to offer administrative leave to people who are put into self-quarantine rather than expect them to take their, individual personal leave, just because we don't want there to be a question about that decision. We have had, at least one or two early on where There was someone returning from travel who was put into self-quarantine, I think, when they traveled very early on to China. And so we were dealing with those issues early on. We also have provided guidance to supervisors about, circumstances where, people are sick and asking them to go home, things like that. So certainly we can provide those.
It's on SharePoint from the 18th. I'll look it up, but yeah, we should have that, is what you're saying. Okay.
It's absolutely already there.
And you said you're considering, but you have not yet changed any travel policies, minimized any conferences, done anything to encourage telework from people that aren't already doing that. Why not? And how long will you wait? What do you want to see before you change any of the policies?
Well, I think to be, this may sound blunt, but there's no reason to do so clinically or based upon epidemiology. And we recognize that it's the balance of being proactive and preemptive and reading the tea leaves, so to speak, in terms of anticipating things. And right now the information does not suggest the need to escalate. However, being mindful of also making sure that as we communicate information with folks, we make sure that they understand that those are the factors that we're using to guide those conversations, because we recognize that once we take action, there will be an immediate response and potentially visceral reaction to that, and we don't want to create unnecessary panic or hysteria based upon the decisions that we make. And so there have been conversations, as Dr. Stoddard mentioned, in terms of, from a human resources perspective, that team has been looking at how to, proactively put in some policies that could be enacted that aren't necessarily, we could potentially have a telework policy that's put into place that doesn't wait until numbers escalate and we move forward. But right now we have planned for these things, but we have advised against moving forward because the evidence simply doesn't support us doing so.
Do you think other large corporations and municipal governments that have put those in place are being rash?
No, I don't think so. Again, I will caution this as saying this is an editorial, not an editorial comment.
Sure.
I think every situation is different. For example, I know the city of Seattle did close their schools, but the reality is they're sitting in a jurisdiction where now they have
different situation.
Double-digit cases,
sure.
fatalities, and there's not a clear understanding of how things are being transmitted. So different settings and different situations, and I think each jurisdiction has responded differently. So, for example, Chicago had some of the earlier cases and have had 2 new cases from community transmission, but they've not moved to close schools based upon the data that they have available.
Right. Closing schools is a certainly more dramatic gesture than scaling back employee conferences, for example, which are more optional. I want to, Councilmember Albornoz referred to some constituents that had traveled abroad that had contacted us. I'm sure we all have heard from different individuals. I got a long letter from somebody that contacted one of our federal representatives. I wanted to just give a couple highlights and see if you have a reaction, because I think it sounds a little bit different than some of the information that we've heard. So this individual, of course I'm not going to give her name, but she's a veteran federal employee, nonprofit employee, and veteran of intergovernmental organizations. So, she's sort of had a lot of experience in healthcare and governmental settings. Spends 3.5 weeks in northern Italy before it was declared a hot zone. Comes back, feels sick, speaks to a virologist, realizes that she is symptomatic and she should get some care, and decides to self-quarantine. Has a very high temperature. This is just 2 weeks ago. Calls a local hospital to see if they were operating any containment measures, and they say no. So she calls MDH, the Department of Infectious Diseases, to see if she could get a test. They said, find a hospital with a containment area. She calls other hospitals, can't find a hospital with a containment area. She checks with her health insurance, and they said they will not cover the cost of going to an ER. She goes to her physician. He calls Maryland State Department of Health, who then calls CDC to ask for test authorization. CDC refuses the test authorization. She's been sick now 10 to 11 days and self-quarantined. She goes to the emergency room at another second local hospital, and the doctor attending her had worked on the SARS outbreak. He says not only does he consider her a potential COVID-19 patient, but that her husband should be tested as well. They have a containment room by this point. They're taking security protocols, and he calls CDC to get a COVID test. He was refused the ability to get a COVID test despite his background with the SARS virus. So her conclusion is that tests aren't available, and this letter came in today, and that the tests that are available after speaking to her doctor are non-reliable based on giving false negatives. Do you have, there's a couple other points, but do you have a thought about what you've heard so far?
Well, first and foremost, I'm not familiar with the case, so I would welcome an opportunity to talk more and get more information, because I would hesitate to make any comments in terms of the rationale and reasoning behind why CDC and the state made the decisions that they did.
Do you know of hospitals that have the ability to quarantine now? They have containment facilities?
Well, there are. I mean, they do. I don't know. I would prefer to have a conversation to find out more information outside of the scope of this to be able to get some more details to answer. But as it relates to the capabilities and capacity of testing, as of this morning, the state can test, and we can do that here. We don't have to send those to CDC, so that would be able to address that particular concern. And again, without knowing more information, background information, I would be cautious and hesitant to comment any further, other than to say that I'm sorry that that was the individual's experience, but I'd like to find out more information as to why the decisions were made in terms of them not getting testing, and, you know, the thought process behind that.
Sure. Yeah. I mean, I think you could appreciate the difficulty she's having, but not just her, but her doctor as well. And given that we might get, that was just one that came in today, we'll likely
I hope that changes,
from other
given that
like
there will be more tests that are available at the state level to be able to test directly as opposed to sending the CDC. And I think one thing that has been helpful also is that there is more guidance. So in addition to testing being available, the treatment algorithm and recommendations changed over the weekend as well to include Italy in that process. So that has evolved. So I would like to think, certainly with that guidance in place now, if she presented coming back from Italy, that would be a different conversation. But much like testing availability has evolved, the recommendations and guidelines have evolved as well in terms of who's being considered at risk, high risk, or medium risk based upon travel history.
But so individuals like that are having difficulty with the hospitals they've encountered, we could put them in touch potentially with your office, and then you...
It would be helpful because then we could, find out more information as to what's happened.
Very, very helpful. Just a couple more questions. One is King County, Washington, has put in place this contingency plan for homeless. I don't know if this came up, maybe I missed it, but do we have a plan, Earl, for our homeless population in terms of testing and treatment?
Yeah, so it's, as Dr. Gales alluded to, it is part of the HHS continuity of operations plan to deal with those who are part of our program to end homelessness. And so absolutely guidance has gone out through MCCH, and we'll continue to do so. And Dr. Gales can certainly go further than this because it's been released to them. But I mean, I will say, I mean, that is certainly a population for whom there may be a number of underlying health conditions that we need to be cognizant of, and those kinds of those kinds of community facilities can be areas where you do potentially see problems, but that's absolutely something we are focused on from a continuity of operations perspective to make sure that we can preserve and protect those kinds of facilities as a priority.
And Superintendent, can I just ask, I appreciate everything you said about the school's preparations. Is there communication already with parents? I'm an MCPS parent. I haven't seen it yet, but I know I'm busy and I miss a lot of stuff. I haven't seen a flyer in a backpack or a robocall yet or anything like that about what the school system's doing, what precautions to take, et cetera.
Sure, thank you. In terms of flyers in the backpack, we know how that happens sometimes. We do tend to, we have put information out. We've sent out a message through our MCPS communications to families. We've been sending out regular updates, just essentially telling families any information that we have that is new and updating them on the fact that we are still in session in schools, and we'll continue to keep them updated with information. So we've been sending information out or emails, and we should check in terms of why you haven't gotten
I'll
that.
check those. I always listen to my robocalls in both languages, and
Yes.
they've been about lost and found and other things like that. Okay, so I'll check the emails.
Yep, and
Is
then
there
our
anything
website.
information about precautions for people to take and the importance of kids to?
Absolutely. So
Right.
that's in the email, and also on all of the information that we have on the website. I spoke earlier about a webpage that we have created
Sure.
on our website in a number of different languages. We have things that are listed as it relates to precautions, and how we are following the situation, and we'll continue to keep the community updated.
Right. Okay. Great. Thank you. Thank you,
Sure.
Mr. President.
Thank you. Thank you all very, very much for being here. We sincerely appreciate it. We know we're going to see you many more times, and probably you care to see us, and we can appreciate that. But we are always glad to see you. So thank you.
May I-
Go ahead, Earl.
may I provide one more
Please.
comment? We talked a lot about people's physical health today, and I think it's really important that as we go through this long exercise,
Yeah.
we think about people's mental health and stress levels too. It is incredibly important that people, not rush to judgment as news changes, and try and keep an even keel. Look for the good, solid information. If you're feeling really stressed, our ABS facilities can provide some resources that can help that as well. I mean, I think it's just really important that we maintain this is a serious situation, but you need to stay, calm and rational about this. I mean, we're going to be doing this for weeks and/or months, and you should prepare to do that.
And you all help us stay calm and rational. You really do. Very good. Thank you very much. We are adjourned.
From Clarksburg Road, Maryland 121 to the truck skills. Slow on Interstate 495 in the following locations.